Good, good morning, everyone. We hope that the other trainees and other participants will join soon. So since we are already late by 8 minutes, we thought of starting now. So we are warmly welcome all of you all on behalf of Sri Lanka College of Hematologists for our third red box, which will be followed by Young Hematologist Forum. I would like to say that this is our last red box for the year 2022. And also I would like to make an announcement. If you have any questions, any burning questions, please post in the chat box, or you can ask verbally when the question and answer session time comes up. Or if you have questions while you're listening the presentations, so you can type them and there in the chat box. And so today we are having speakers from two clusters, a Gold cluster and Candy Peradeniya cluster. Gold cluster, actually, we don't have any trainees from Ruhunu faculty. So basically the trainees based in Teaching Hospital Karapitiya will be presenting a case. So without taking much time, I'll introduce the speakers from Candy Peradeniya cluster because they will be presenting first. And we have 3 presentations from them today. And the first presentations will be on sweet does the word always represent sweet things. Will be presented by Dr. R.M.B.J. Ekanayaka, who is a senior registrar in clinical hematology, National Hospital of Kandy, and Dr. M.N.F. Shapana. She's a registrar in clinical hematology. She's also attached to National Hospital of Kandy. Over to you, Shapana.
Good morning, everyone. Let's move on to the first presentation of the day. Mr. S, 61-year-old male, driver. Father of 3 children from Kandy. He was a kidney donor and there was no other significant comorbidities. He presented to us in 2020 November with generalized malaise and easy bruising, and by that time he was found to have pancytopenia with a HB level of 8 gram, neutrophil count of 0.9 with a platelet count of 30,000. By that time, bone marrow biopsy was done and diagnosed as myelodysplastic syndrome with multilineage dysplasia. Cytogenetics was done, which was normal karyotype. According to RIPSS risk stratification, he was risk stratified as low risk group. By that time, he was managed with transfusion support and neutropenic precautions was taken. According to Nordic score, he had a Nordic score of 1. Therefore, we started erythropoietin therapy. He was defaulted follow-up due to COVID pandemic and financial issues. He admitted to the medical ward with neutropenic sepsis and managed with broad-spectrum antibiotics and granulocytic colony-stimulating factors in 2021 July. 2 weeks after discharge, he presented to OPD with an erythematous skin lesion over his right arm. What would be the differential diagnosis by this time?
So this is a 61-year-old diagnosed patient of MDS MLD in low risk category, and he was on hipotherapy but defaulted follow-up for 6-month duration. And he was recently treated for neutropenic sepsis treated with IV antibiotics and GCSF. 2 weeks later, he presented with an erythematous skin lesion on the right arm. So my differential diagnosis is this could be due to disease-related condition or disease-unrelated condition. Disease-related condition could be skin sepsis due to neutropenia, purpura due to thrombocytopenia, or the leukemia cutis. The disease-unrelated conditions could be allergic skin reaction or any other dermatological condition.
This was the skin lesion of our patient. It was a single erythematous, roughly circular infiltration with a juicy appeared plaque with central area of hyperpigmented bullous. Along with this rash, he had high-grade fever with arthralgia and myalgia. There was no any skin lesions or bleeding manifestations seen. No clinical features suggestive of other systemic infection as well. The skin lesion was painful, non-itchy, and abrupt onset. By that time, his full blood count shows HB value of 7.5 gram per deciliter, neutrophil count of 0.87 with a platelet 35,000. We did the inflammatory markers on him, where the CRP was 70, ESR was 12 mm in first hour, with a procalcitonin level of 0.07, which excludes the possibility of infection. What would be the next management in this patient?
First, I would manage the patient symptomatically with transfusion support and antipyretics and hydration. But for the dermatological lesion, I would like to take dermatological opinion.
We have taken a dermatological opinion and skin biopsy was done. The skin biopsy shows dense neutrophilic infiltration in reticular dermis with capillary edema and interstitial infiltration of leukocytoplastic nuclear debris, which resembles acute febrile neutrophilic dermatosis, which is also known as Sweet syndrome. What are the diagnostic criteria of Sweet syndrome?
The diagnosis criteria of Sweet syndrome, there are major criteria and minor criteria. Major criteria are abrupt onset of typical cutaneous lesion, histopathology consistent with Sweet syndrome. Minor criteria are associated with underlying diseases such as infection, malignancy, inflammatory disorders, drugs or pregnancy. And second one is presence of fever and constitutional symptoms. Third minor criteria is leukocytosis. Fourth one is excellent response to systemic corticosteroids. For the diagnosis of Sweet syndrome, both of major criteria and two minor criteria are needed.
Considering the history of MDS with recent GCSF therapy, with the current clinical picture, along with the characteristic skin lesion and histology evidence, a diagnosis of Sweet syndrome was made in our patient. What is Sweet syndrome? Can you please elaborate on that?
Sweet syndrome is a rare disorder characterized by fever and rash. It is also known as acute febrile neutrophilic dermatosis. Depending on the triggering factor, there are three subdivisions. The first one is classic Sweet syndrome, which is also named as idiopathic Sweet syndrome. It is the commonest subtype. And second one is malignancy associated Sweet syndrome, which carries poor prognosis. And third one is drug-induced Sweet syndrome. The characteristic rash in Sweet syndrome include painful plaques and nodules with occasional blisters and pustules within the lesion. This rash usually occurs in the face, trunk and upper limbs. The histopathology of the rash shows papillary edema with dermal neutrophilic infiltration. In addition to fever and rash, there are systemic manifestations including inflammatory arthritis, and also internal organs, conjunctivitis can be the presenting feature. There are many associated triggering factors for Sweet syndrome. The first one is infection. Viruses such as cytomegalovirus, HIV, hepatitis B and C, and bacteria such as streptococci and Mycobacterium tuberculosis, leprosy, BCG vaccination, and fungi are the non-causing factors for Sweet syndrome. In malignancy, hematological malignancies like AML, MDS, CML, multiple myeloma and lymphoma are precipitated to Sweet syndrome. Among all these malignancies, the commonest malignancy associated with Sweet syndrome are AML and MDS. And other solid organ malignancies like carcinoma, mainly the carcinomas are associated with Sweet syndrome. And GI disorders like Crohn's disease, ulcerative colitis also precipitated to Sweet syndrome. When it comes to the drug, there is a long list of drugs. The most commonly associated drugs it is included in this slide. The drugs used in hematological disorders like GCSF, ATRA, bortezomib, azathioprine, lenalidomide and imatinib can cause sweet syndrome. Among all these drugs, the most frequently implicated drug is GCSF, and also the antibiotics such as cotrimoxazole nitrofurantoin, anti-epileptics such as carbamazepine diazepam, and contraceptives like levonorgestrel, NSAIDs like celecoxib diclofenac sodium, diuretics, furosemide, and antipsychotics also can precipitate to sweet syndrome. And the other autoimmune diseases such as SLE, rheumatoid arthritis, dermatomyositis also show the association between sweet syndrome. The miscellaneous causes such as primary polycythemia, bone marrow and renal transplant, pregnancy, thyroiditis, erythema nodosum, sarcoidosis are the known triggering factors for sweet syndrome.
Considering our patient with underlying hematological malignancy, which was myelodysplastic syndrome with multilineage dysplasia and a recent treatment with GCSF therapy, we consider them as the precipitated factors to sweet syndrome. What could be the treatment options in this patient?
Isolated skin manifestation is a benign condition that may involute spontaneously and rarely leaves a scar. Recurrence develop in 30% of cases with or without treatment, and more often in patients with hematological malignancies. The sweet syndrome related to infection improves when the underlying infection is treated. The available treatment options are: first-line treatment is steroid, oral prednisolone 0.5 to 1 mg per kg per day for 2 to 6 weeks, prolonged low-dose steroid for 2 to 3 months to reduce the risk of recurrences, topical or intralesional steroids for local skin lesions. The other second-line agents are cyclosporine, potassium iodide, dapsone, colchicine, and infliximab.
Patient has been managed with oral prednisolone 1 mg per kg daily dose, which was continued for 2 weeks and gradually tailed off. Patient was managed symptomatically and red cell transfusion was done. GCSF was withheld due to the as it is a predisposing factor here for the sweet syndrome. The skin lesion and cyst symptoms were improved gradually. On discharge, his full blood count shows HB of 8.5 gram per deciliter with neutrophil 1.07 and platelet count of 33,000. The patient defaulted due to COVID pandemic and economical issues, but there were recurrent admissions to medical wards due to neutropenic sepsis and exacerbation of sweet syndrome. The management dilemmas in this patient: there were recurrent infection due to severe neutropenia with underlying disease, NDS, and as well as with steroid treatment which was given for sweet syndrome. As well as he is a kidney donor, therefore we were unable to start cyclosporine as a second-line agent for sweet syndrome. The poor compliance and the financial issues lead to defaulted follow-up in this patient. Our patient has been managed in a multidisciplinary team approach. Yeah, the neutropenic sepsis, we gave broad spectrum antibiotics with microbiological team opinion. The sweet syndrome exacerbations were treated with colchicine, which is a second line treatment, with the dermatology team support. For the severe neutropenic sepsis, since we are unable to give GCSF here, we gave Buffycode with the transfusion team opinion, but we couldn't continue Buffycode because the patient developed transfusion reaction. He also had severe thrombocytopenia and also had a platelet refractoriness where the patient did not responding to random donor platelet transfusion. Therefore, with the transfusion team opinion, we have transfused apheretic platelet for him. Patient presented to us again with a hematemesis and melena. What are the possible causes here and what are the management issues now?
Possibilities of this patient who presented with hematemesis and melena: it could be a steroid-induced gastric erosions, and also esophageal and gastric mucosal involvement of sweet syndrome is a possibility. When the management, first I would resuscitate the patient, then I would prefer medical management for this patient because of that pathology phenomenon. That means the hyperreactivity response to invasive procedure. Every invasive procedure, even a needle prick injury, further aggravate the sweet syndrome because of pathology phenomenon. If the medical management is failed, I would like to go for the invasive treatment option like upper GI endoscopy and fibrin sealant like option, but cautiously, without doing any biopsy or any other invasive procedure, cautiously, I would like to go for upper GI endoscopy with liaison with the gastroenterology team.
Our patient was managed initially with the IV proton pump inhibitors, to which he was not responding. Therefore, we have taken gastroenterology team's opinion and upper GI endoscopy was done. To the lesion, they have applied a fibrin sealant. Transfusion support was done for the cytopenias. The patient had recurrent hospital admissions and disease-related complications, which leads to depression in the patient. For that, we have taken psychiatric opinion and antidepressant drugs were started. For the recurrent severe exacerbation of Sweet syndrome, dermatology team has suggested to start infliximab in this patient. He next presented to us with multiple skin lesion and conjunctivitis, which are cutaneous and extracutaneous manifestation of Sweet syndrome, but it was considered as severe exacerbation of Sweet disease. Along with that, the patient had worsening of pancytopenia as well, where the blast cells were 15% in bone marrow, and which we concluded it as myelodysplastic syndrome with excess blast type 2, where the patient came to a high-risk category. But karyotyping couldn't arrange by this time due to financial issues. The management of the current presentation, multidisciplinary team approach was done. For the Sweet syndrome, we have started low-dose steroids with infliximab. Since he is a high-risk MDS patient, transfusion support for cytopenias were done, and also we have planned to start azacitidine in this patient. But unfortunately, the patient developed generalized tonic-clonic seizures while in the ward with the multidisciplinary team management. NCCT brain was done, which reveals multiple intracranial hemorrhages and mass effect, possibly due to CNS manifestation of the Sweet syndrome. While awaiting neurosurgical management, the patient unfortunately passed away.
When consider the prognosis of Sweet syndrome, most cases of Sweet syndrome are resolved spontaneously, but some persist indefinitely and are difficult to manage. The overall prognosis depends on the underlying disease, and the malignancy associated Sweet syndrome carries a poor prognosis. Recurrence occurs up in 50% of patients and is most likely in case associated with hematological malignancy and drug reactions. The take-home messages are Sweet syndrome is a rare dermatological disease associated with hematological malignancies, and drugs were used in hematological conditions. Invasive procedures should be minimized to prevent the pathology phenomenon. The presence of Sweet syndrome may serve as a predisposing factor for the rapid transformation of MDS patients. Early identification and prompt treatment of Sweet syndrome and underlying diseases are mandatory to prevent further relapses and prevent progression of underlying myelodysplastic syndrome. These are our references, and this comes to the end of our presentation. Thank you very much for your attention.
Thank you, Dr. Budika and Dr. Shafana, for your excellent presentation on Sweet syndrome, which is one of the rare things that we do see, not frequently see. So thank you for enlightening us on and also relating to that with the MDS, because if patient comes with that, then of course we have to be a bit vigilant on that, because they can progress into high-risk disease. So that's one of the good things that we learned from you all. Thank you so much. And if you have any burning questions, please type on the chat box, and we can take those questions at the end after the two presentations from the other colleagues, and we'll ask from them the answers. So we'll move on to our second presentation, again from the Kandy cluster. They will be talking on a lady with fever and rash, which will be presented by Dr. N.K. Samarakun, who is a registrar in clinical hematology attached to National Hospital of Kandy, and Dr. J.M.H.C. Mudalike, she is a diploma trainee in hematology, She's also attached to National Hospital, Kandy. Over to you, Dr. N.K. Samarakonan Mudalike.
Good morning, everyone. Let's move on to our case presentation. A lady with fever and rash. Our patient is a 34-year-old female, mother of 2 children, presented with high-grade fever for 1 month duration, associated with multiple joint pains involving both small and large joints, painful oral ulcers, and over the next 2 weeks, she developed erythematous rash on her cheeks, and it was gradually increased and involved the trunk and back. She also complained of loss of appetite for 1 month duration, but no night sweats or loss of weight, no chest pain, cough, hemoptysis or sputum production. Bowel habits were normal. She complained of frothy urine, but no other urinary symptoms. There were no recent travel history, exposure to animals, and no high-risk sexual contacts or history of blood transfusions. On general examination, she was febrile and pale, and there was erythematous maculopapular rash over male area of the face and trunk, and oral ulcers. There were no jaundice, lymphadenopathy, ankle edema, or peripheral stigmata of infective endocarditis. On cardiovascular system examination, pulse rate was 90 and it was regular. Blood pressure normal and heart sounds were normal with no murmurs. Respiratory examination was normal. On abdominal examination, there were mild tender hepatomegaly but no splenomegaly. Neurological examination unremarkable. Musculoskeletal examination, there was arthralgia but no joint swelling or deformity. In summary, she is a 35 years old female presented with persistent fever with joint pain, oral ulcers and skin rash for 1 month duration. On examination, there was generalized erythematous maculopapular rash with mild hepatomegaly without splenomegaly or lymphadenopathy. So we have performed the full blood count. So it shows pancytopenia with hemoglobin of 9 gram per deciliter. WBC was 2.15 with moderate neutropenia, and platelet count was 67,000, moderate thrombocytopenia. ESR and CRP were normal. Blood picture, it showed as evidence of pancytopenia with no abnormal cells. In liver profile, AST, ALT were high. Other than that, total bilirubin, direct bilirubin, total protein and albumin were normal. In UFR, it shows albuminuria with albumin 3+, but creatinine, blood urea, sodium and potassium levels were normal. Her coagulation profile showed normal PT, INR and APTT value, but her fibrinogen level was 112 milligram per deciliter, which is low. And USS abdomen shows mild hepatomegaly, and LDH value is mildly elevated. 2D echo shows normal ventricular function of ejection fraction more than 60%. So at this point, patient became very ill and her cytopenia get worsened. So we suspect HLH at this point in this patient. So we have investigated for that. And we have done serum ferritin and triglyceride levels. Serum ferritin level was around 13,000, which is very high, and triglyceride level also high. So we have done the bone marrow biopsy, and bone marrow aspiration and refined biopsy shows increased macrophage activity with hemophagocytosis and no evidence of bone marrow infiltration by lymphoproliferative disorder or other hematological or non-hematological malignancy. Dr. Nimali will continue from here onwards. Thank you all.
Good morning, everyone.
I will be discussing the second half of the presentation. According to the clinical and laboratory criteria which are described by the Dr. Hasara, we diagnosed to have our patient having hemophagocytic lymphohistiocytosis, which are compatible with the HLH 2004 diagnostic criteria. What is hemophagocytic lymphohistiocytosis? It's a severe hyperinflammatory syndrome induced by aberrantly activated cytotoxic T cells and macrophages, causing tissue infiltration by lymphocytes and macrophages, leading to hemophagocytosis. This rapidly progresses into multi-organ failure and death. Moving on to the causes of HLH, there are two main categories, primary HLH and secondary HLH. Primary HLH are associated with the genetic defect in the immune system, which can be transmitted with autosomal recessive inheritance patterns. There are defects in the cytolytic functions of the cytotoxic T cells or NK cells, such as perforin 1, MUNC13, 4 like genetic mutations, or defects in inflammasome regulation like syntaxin 11 defect. The most common cause of secondary HLHs are the viruses like Epstein-Barr virus, HIV, cytomegalovirus, and bacteria, parasites, and fungi can also associate with the secondary HLH. Malignancies include mainly the hematological malignancies like Hodgkin lymphoma or non-Hodgkin lymphoma, as well as the other solid malignancies. The HLH associated with autoimmune conditions are known as macrophage activation syndrome. Other causes include organ or stem cell transplantation, trauma, iatrogenic causes like immunosuppression, vaccination, surgery, hemodialysis, and rarely this can be associated with pregnancy. Moving on to the pathogenesis, the hallmark of HLH is the T cell driven, aberrantly hyperinflammatory, hyperperitoniemic immune response. There's always a trigger, as I described earlier, which causes cytotoxicity defect in the immune system, which causes the uncontrolled T cell lymphoproliferation, leading to interferon gamma secretion. This will activate a large number of macrophages, causing excretion of cytokines like interleukin 6, 10, TNF. This causes the cytokine storm and tissue infiltration of T lymphocytes and macrophages, causing hemophagocytosis. There are no specific clinical features in the HLH, but the patient can have persistent fever for more than 7 days and temperature about 38.5 degrees Celsius, and abdominal pain, vomiting, diarrhea, anorexia, arthralgia, bleeding diathesis, and CNS involvement cause seizures, ataxia, hemiplegia, and irritability, and failure to thrive in children. And they can have pallor with easy bruisability, lymphadenopathy, hepatomegaly or splenomegaly, and 65% of patients can have associated with rashes like erythroderma to generalized purpuric macules and papules to mobiliform eruptions. And they can have jaundice or edema. And their baseline investigations will show peripheral cytopenias in full blood count and blood picture, and raised liver enzymes, raised albumin, and hyperbilirubinemia in liver function test, and hyperfibrinogenemia and increased D dimers with normal PT and APT in the coagulation studies, and elevated LDH, and characteristically they will have hypertriglyceridemia and hyperferritinemia more than 10,000. Moving on to the HLH 2004 diagnostic criteria, there are two major criteria. First one is the molecular diagnosis consistent with HLH, and second one is the 5 out of 8 clinical criteria shown below. Out of these criteria, either one is fulfilled, we can diagnose as HLH. Clinical criteria include fever for more than 7 days and splenomegaly, cytopenias 2 out of 3 lineages in peripheral blood. This includes hemoglobin less than 9, platelet less than 100, or either neutrophil count less than 1. And hypertriglyceridemia measured in fasting triglyceride, which will be more than 265, and low fibrinogen level less than 1.5 grams per liter. And hemophagocytosis in bone marrow, spleen, and lymph nodes, low or no NK cell activity, and raised serum ferritin more than 500 grams per liter, and soluble CD25, which is a marker of macrophage activation, which will be increased more than 2400. And little bit about the genetic test in HLH. This is useful in diagnosis of primary HLH, but generally not recommended in adult patients as primary HLH is rare, but can be indicated in patients with family history of consanguinity, partial albinism, and recurrent disease of HLH, or young male adults with Epstein-Barr viral infection or lymphoproliferation, or HLH patients with unknown trigger. We can use next generation sequencing, gene panels, or whole exome sequencing. As I described earlier, there is always a trigger in HLH, which can be infection or autoimmune disorder or malignancy. 40 to 70% of HLH cases are associated with malignancy in adults, which can present at the presentation of the malignancy or initiation of chemotherapy or remission due to the immunosuppression. The most common malignancies are hematological malignancies, including Hodgkin lymphoma and non-Hodgkin lymphoma. In these patients, we can arrange bone marrow biopsy with immunophenotyping, PET-CT, soluble CD25 into serum ferritin ratio, splenectomy for diagnosis. Then a little bit about the management of HLH. We use HLH94 protocol, which consists of steroids, typically dexamethasone, and cyclosporine A, intrathecal therapy, and etoposide. And this drastically improved the fatal outcome of these patients. It causes the deletion of the activated T cells and suppression of inflammatory cytokines that are produced. Etoposide is a chemotherapeutic agent, has high specificity against T cell lymphoproliferation and cytokine secretion. And this is the diagrammatic representation of HLH94 treatment protocol. It has initial therapy and continuation therapy. Initially, we started with dexamethasone 10 mg per square meter for 2 weeks duration, and later we tailed off between 2 weekly intervals. And etoposide therapy started twice weekly therapy, and later we can tail off according to the response. And cyclosporine A introduced to maintain the blood level around 200 micrograms per liter. Intrathecal therapy with methotrexate introduced in patients with neurological symptoms. So back to our patient. As I discussed earlier, there's always a secondary cause for HLH. Then we further investigate our patient to identify a cause. Her viral screening with HIV, hepatitis A, B, EBV, and CMV came as negative. But interestingly, her ANA was positive with nuclear pattern more than 1 in 8. And her complement levels, including C3 and C4, were low. And as she had skin rash, we go ahead with the skin biopsy, which was compatible with lupus erythematosus, and renal biopsy compatible with class 5 membranous lupus nephritis. Then we diagnosed her to have systemic lupus erythematosus, which is an autoimmune disorder characterized by autoantibodies to nuclear and cytoplasmic antigens, which involves the multisystem inflammation with protean clinical features and relapsing and remitting cause. They can be presented with fatigue, fever, or loss of appetite, and musculoskeletal system involvement like arthralgia, myalgia, joint swelling, and malar rash, photosensitivity, discoid lupus. They can present with AKI or CKD with acute nephritic syndrome, or they will have CNS manifestations like seizures, psychosis, and pleural effusion, pulmonary hypertension, interstitial lung disease, and they can have non-specific GIT symptoms like nausea, dyspepsia, abdominal pain, and they can present as pericarditis, myocarditis, or hematological involvement like cytopenias. These are the latest diagnostic criteria of SLE, which are described by ACR and EULR criteria. All patients should have ANA value at least 1 into 8, and 10 10 of these criteria should be fulfilled. And moving on to the macrophage activating syndrome, it is a subset of HLH arising on the background of systemic autoinflammation like our patient had. It can be associated with Still's disease, lupus, vasculitis, and other autoimmune disorders. And management of the macrophage activation syndrome. These corticosteroids are the first line of treatment. High dose of pulse of methylprednisolone is the frequently used approach. Then cyclosporin A can be added to these patients with insufficient response to the methylprednisolone. Novel agents like anti-leukin-1, anti-leukin-6 blocking agents or etoposide can be used in refractory patients. Then a little bit about how we managed our patient. Initially, she was diagnosed to have HLH. For that, we started IV dexamethasone therapy according to the HLH 94 protocols, which she showed a dramatic response, and then we tailed off the treatment. And while investigating to identify the cause, she was diagnosed to have SLE according to the EU-LAR ACR criteria, and later she was diagnosed to have macrophage activation syndrome in SLE. And for that, we started her on hydroxychloroquine later. And currently, she is being followed up at rheumatology clinic and hematology clinic without any relapses. And this brings us to our second presentation. These are our references. And thank you.
Thank you, Dr. N.K. Samarakun and the Dr. J.M.C. Mudalike for your excellent talk on SLE and how the macrophage activation syndrome. And we will be hearing more on HLH management, which will be delivered by one of our young hematologists in the Young Hematologist Forum, which will be followed after this red box. So we are waiting to hear what she's going to discuss on more on management and how the complication and things like that. And we'll move on to our third presentations from a Candy cluster. It's on when there is no enemy outside, enemy may be inside. This looks like very interesting topic. Like I'm eagerly waiting to listen what they are going to talk on this topic, and which will be presented by Dr. G.C.M. Veerasurya, Diploma Trainee in Clinical Hematology, and Dr. D.T. Ekanayaka, she's a Registrar in Clinical Hematology. Both of them are attached to Peradeniya University. So over to you, both of you all, for your presentation.
Good morning, everyone. Let's move on to another interesting case scenario. Our patient, Mr. R, who is a 69-year-old male patient, who is a previously healthy patient, presented to us with a shortness of breath and epigastric pain for 2-week duration. At that time, there was no any chest pain or any features to suggest heart failure. And also, he didn't have any history of constitutional symptoms or any chronic cough. And also, there was no any history of bleeding manifestation or including melena. There was no any history of oral ulcers, joint pains, or any photosensitivity rashes to suggest any autoimmune diseases. And there was no any symptoms to suggest any splenomegaly like abdominal distension or early satiety. And also no evidence of hemolysis. And also there was no any history of chronic back pain, altered bowel habit, or symptoms suggestive of bladder outflow obstruction to suggest any solid malignancy. In his past history also, there was no any history of blood transfusion, and his family history also revealed no any history of recurrent blood transfusion or any history of hemoglobinopathy or any solid malignancy history. He is a non-vegetarian person and a non-smoker, also a non-alcoholic person. He denies any chemical, pesticide or radiation exposure too. And also he denies any high-risk behavior or foreign travels. On examination, he was afebrile but pale, not icteric, no evidence of any chronic nutritional deficiencies. There was no any oral ulcers, skin rashes or lymphadenopathy. And also there were no any peripheral edema. Respiratory system examination and cardiovascular and the neurological examination findings were unremarkable. On abdomen, there was no any hepatosplenomegaly or any masses. In summary, this is a 69-year-old previously healthy non-vegetarian male patient presented with anemic symptom without chronic blood loss or hemolysis or features to suggest any hematological or non-hematological malignancy. Then move on to our investigation findings. His full blood count, WBC, normal total WBC count with differential counts, and platelet also normal. But there was anemia with 7 gram per deciliter with marginal indices with hyperchromic microcytic indices. His blood picture was a hyperchromic microcytic red cells with normochromic normocytic red cells and few teardrop cells with mild polychromasia. In WBC, normal total number with neutrophil predominance, there were no abnormal cells. Platelets were normal with normal morphology. According to the blood picture, the features were suggestive of an iron deficiency anemia. This is his hemolytic screening that shows the retic count was 2.1% with normal total bilirubin and indirect fraction. LDH was 320 and that also negative. Then move to the iron studies. Ferritin was 20 nanogram per milliliter with transferrin saturation was 17% with serum iron was 6.8 micromole per liter, showing a mild iron deficiency anemia. Then stool occult blood also found to be negative. To find out any cause for iron deficiency, he underwent an upper GI endoscopy that showed a mild antral gastritis, and also the duodenal biopsy also performed due to some gastritic features, but that also found to be normal. His basic liver enzyme and the total protein albumin all were normal. At that time, he presented with a shortness of breath, but the ECG didn't show any evidence of ischemic changes. The chest X-ray also found to be normal. In the USS abdomen, there was a grade 1 fatty liver, but no hepatosplenomegaly. ESR was 62 mm in first hour. In the initial management, after the basic investigations, 2 units of red cell concentrate were transfused at the ward and he was started on treatment dose of iron with vitamin C. For the gastric symptom, he was started on 14 prum inhibitors. After 3 months following initial presentation, he came to the hematology clinic with the full blood count report that showed normal total WBC count with neutrophils and the platelet, but hemoglobin was 9 compared to a presentation that was increased up to 9 gram per deciliter with the blood transfusion and the iron treatment. But 2 months later, again he complained of anemic symptoms, but there was no any history of bleeding or any constitutional symptoms. At that time, his WBC count was normal with the normal neutrophils, but anemia was detected with 7.2 gram per deciliter with the marginal thrombocytopenia. At that time, as he was anemic with the symptomatically anemic, he was transfused 1 pint of blood. So here, do we need to reevaluate the patient? Of course, we thought to reevaluate the patient to find out the cause for anemia. So we repeat the blood picture. That blood picture showed normochromic normocytic red cells with the teardrop cells, polychromatic cells and NRBC. WBC, normal total count with normal neutrophils with the left shifted up to myelocytes, but there were no any abnormal cells, including immature cells. Platelet, there was mild thrombocytopenia with normal morphology, but there was no any significant anisocytosis. So this is a leukoerythroblastic blood picture. I think you can appreciate there is a teardrop pericytosis. Then we go ahead with the bone marrow aspiration, but that was a blood tap aspiration. Then we had to wait till the trephine biopsy. The trephine biopsy was a 1.5 centimeter adequate trephine biopsy. Sections of bone marrow showed thickened bone trabecular architecture with hypocellular marrow spaces for the age, and the suppressed trilineage hematopoiesis were noted. Areas of cellular streaming were noted with multifocal fibrosis. There are scattered atypical cells with convoluted nuclei and eosinophilic cytoplasm. At that time, our DD were whether this is a secondary deposit or a Hodgkin lymphoma or primary myelofibrosis. So suggested to do immunohistochemistry for further confirmation. At that time, we did a reticulin stain that was found to have grade 2 reticulin stain positivity. These are the pictures of trephine biopsy. This is reticulin stain. As the bone marrow trephine biopsy suggestive of a malignancy from a primary site, so we did malignancy screening with the CT abdomen, chest and pelvis. That also found to be normal. Prostate specific antigen, it also normal. Serum protein electrophoresis only showed the polygonal band. Then go ahead with the lower GI endoscopy, that also normal. So meanwhile, the immunohistochemistry also found. So the pan-cytokeratin negative, leukocyte common antigen highlight a reactive small lymphocyte population with some large cells or variable positivity. CD34 immature marker also negative for the large cell cluster, and the CD30, CD15, CD79A, CD3 and desmin all were negative. So the possibility of metastatic deposit carcinoma or lymphoma excluded at that time. So as the bone marrow was fibrotic, we did a JAK2. JAK2 V617F mutation found to be positive. At that time, the patient was diagnosed to have primary myelofibrosis in the overt fibrotic stage. 6 months following its initial presentation with DIP score of 3, intermediate risk category. Then move to his management. He was started on trial of erythropoietin with subcutaneous erythropoietin 30,000 per week for 8 weeks, but he showed a poor response to erythropoietin. Then he was started on danazol with starting dose of 200 mg daily and increased up to maximum dose. Continued for a 6-month duration, but he needed recurrent blood transfusion while on danazol, but there was no any bleeding or infection during this course. As he not responded to danazol, he was started on trial of prednisolone and thalidomide. Fortunately, he showed a good response within 1 month of treatment. Currently, he is being following up at hematologic clinic TH Peradeniya, and also he was on prednisolone and thalidomide. Transfusion support has not been given for last 6-month duration, and also he is clinically asymptomatic and having stable full blood count with the hemoglobin and platelet without transfusion. In summary, this is a patient who was presented with symptomatic anemia without splenomegaly, diagnosed to have primary myelofibrosis. This is a rare presentation of myelofibrosis, as almost all patients has splenomegaly at the presentation or develop splenomegaly during the course of illness. Now I invite Dr. Tilini to continue rest of the presentation. Thank you.
Thank you, Chamari. and good morning to you all. I'm going to continue the presentation from there. Primary myelofibrosis, it is a clonal myeloproliferative neoplasm and it is characterized by proliferation of predominantly abnormal megakaryocytes and granulocytes in the bone marrow. In fully developed disease, it is associated with reactive deposition of fibrous connective tissue with extramedullary hematopoiesis. There is stepwise evolution from an initial prefibrotic stage to an overt fibrotic stage with marked reticulin or collagen fibrosis in the bone marrow and often osteosclerosis. This diagram I have included the progression of myelofibrosis from the initial phase where is pronounced thrombocythemia without blast, no or borderline anemia, splenomegaly, normal or borderline LDH, and with time it gradually progressed to overt fibrotic stage and often blast phase with bone marrow insufficiency. It becomes a reduced platelet count, leukoerythroblastosis, anemia, splenomegaly, and increased LDH. With the time, bone marrow fibrosis gradually increased and relative survival become low with the progression of the disease. If we see the pathogenesis of primary myelofibrosis, JAK-STAT activation is the central theme, and there are three driver mutations: JAK2 V617F or JAK2 exon 12 mutation, CALR mutation, and MPL mutation. JAK2 V617F and exon 12 mutation. This JAK2 molecule is this red color one attached to this MPL receptor, EPO receptor, and GCSF receptors. It has two domains, catalytic kinase domain and pseudokinase domain, which prevents cytokine independent self-activation, and it inhibits this kinase domain. This mutation, both mutation affect this pseudokinase domain, and it leads to cytokine independent activation of these receptors and cytokine hypersensitivity. So when JAK2 V617F and exon 12 mutation are there, these intracellular signaling pathways are activated and cell proliferation occurs irrespective of cytokine and hypersensitivity to cytokines. And NPL mutation, it occurs in W515 position, and when it is mutated, it also stabilizes the receptor in its activated form. So it activates the cell signaling pathways irrespective of thrombopoietin, as this MPL is thrombopoietin receptor. And the other one is CALR mutation. It is actually not a signaling molecule. It is a ER chaperone. It involves the quality control and it helps the trafficking the matured MPL receptor through the cell membrane. When this CALR is mutated, after trafficking this receptor into the cell membrane, it doesn't detach from the receptor and remain attached, and it remains in the activated form. Again, with that, the cell signaling pathways are activated, and with all these three mutations, cell proliferation increase with megakaryocyte proliferation, vascular endothelial growth factors, and growth factors increase secretion in the bone marrow, which stimulate the fibroblast proliferation and ultimately causing the bone marrow fibrosis. If you see the clinical presentation, they can present with severe anemia, marked hepatosplenomegaly, constitutional symptoms, bone pain, splenic infarct, pruritus, thrombosis, and bleeding. Ineffective erythropoiesis and hepatosplenic extramedullary hematopoiesis are the main causes of anemia and organomegaly, and there can be other disease complications like symptomatic portal hypertension that might lead to variceal bleeding or ascites, and non-hepatosplenic extramedullary hematopoiesis leading to cord compression, ascites, pleural effusion, pulmonary hypertension, or diffuse extremity pain. Diagnosis of primary myelofibrosis is based on 2016 WHO criteria, and there is no difference in 2022 revised criteria. It involves composite assessment of clinical and laboratory features. Diagnosis need bone marrow examination with karyotyping with driver mutation analysis. These are the diagnostic criteria for prefibrotic myelofibrosis. It has major criteria and minor criteria. And this is the diagnostic criteria for overt fibrotic myelofibrosis. It also has three major criteria and 3 major and minor criteria, 5. The difference is this first major criteria in prefibrotic, there is no fibrosis, but in overt fibrotic stage, we appreciate megakaryocyte proliferation with an atypia with reticulin or collagen fibrosis. WHO criteria for other essential thrombocythemia, polycythemia, chronic myeloid leukemia, MDS, are not met, and the presence of JAK2, CALR or MPL mutation or any another clonal marker, or absence of reactive myelofibrosis. We need all 3 major criteria and at least 1 minor criteria. This minor criteria need to be confirmed in 2 consecutive occasions. Minor criteria: anemia not attributed to comorbid conditions, leukocytosis more than 11,000, palpable splenomegaly, LDH level above the upper limit, and leukoerythroblastosis. Here I have included few pictures of myelofibrosis. We can see this blood picture shows that teardrop poikilocytosis with nucleated red cells and left shifted maturation of granulocytes causing leukoerythroblastosis, and bone marrow trephine biopsies with dense clustering of abnormal megakaryocytes. And here the reticulin stain, increased reticulin fibrosis, and this picture shows a marked increased intrasinusoidal hematopoiesis with widening of sinusoidal spaces. If we go into the staging and risk stratification of myelofibrosis, there are many prognostic models like IPSS, DIPSS, and this DIPS plus, MIP70, MIP70 plus version 2, and GIPS. This IPSS scoring system we can apply at the time of diagnosis, which include age, constitutional symptoms, hemoglobin, WBC, and circulating blast. DIPS score has the same factors, but this DIPS score we can apply at any time during the clinical course. And DIPS plus score, it include additional to this DIPS score, it has red cell transfusion need, platelet count, and unfavorable karyotype. In our setting, we use this DIPS score to the patients, but when the karyotyping is unable to do, we can go with this DIPS score also. This is the MIP70 risk stratification method with genetic variables and clinical variables. This is MIP70 version 2, also having genetic and clinical variables, and this GIPS score has only the genetic variables. If you go into the management of myelofibrosis, treatment depends on the risk stratification of the patients, and there are several treatment algorithms. Only treatment modality that is capable of prolonging the survival or potential cure is allogenic hematopoietic stem cell transplant. Unfortunately, transplant in myelofibrosis is currently associated with at least 50% rate of transplant-related death or severe morbidity. Therefore, risk of transplant must be balanced against the expected survival without transplant. This is the treatment algorithm for myelofibrosis depending on DIPS plus score. If they are very low risk disease without symptomatic splenomegaly, we do observation alone. If they have symptomatic splenomegaly, we can treat this symptomatic splenomegaly. Low risk disease, again without symptoms, without symptomatic anemia or splenomegaly, we can observe. If they have symptoms, we can go with the symptomatic treatment. Intermediate high risk and high risk disease, the treatment option is stem cell transplant. If they are not fit for transplant or any difficulties for this transplant, again, we do the symptomatic management with supportive care. Supportive care, mainly we address treatment of anemia, treatment of splenomegaly, and treatment of constitutional symptoms. Treatment of anemia, we can do red cell transfusions, and iron chelation is not generally recommended. Erythropoietin we can use for anemic patients, but in newest guidelines, they do not encourage erythropoietin, but in our settings, we use erythropoietin. And we can use androgens and thalidomide with or without prednisolone. We can try for treatment of it is recommended for treatment of anemia, and lenalidomide with or without prednisolone is another treatment option. Treatment of splenomegaly, we can do it medically with JAK2 inhibitors like ruxolitinib, hydroxyurea if there is no cytopenias. If there is cytopenia, thalidomide and prednisolone can be used. Splenectomy is another treatment option for drug refractory symptomatic splenomegaly, which is associated with portal hypertension. Radiotherapies also can be used for patients who are unfit for surgery for splenectomy. Those who are unfit, we can use radiotherapy. Treatment of constitutional symptoms, we can use JAK2 inhibitors like ruxolitinib. And a little bit about ruxolitinib, it can anemia and thrombocytopenia should be anticipated, and peaking it at 12 to 16 weeks and then improve. If patient already has anemia and thrombocytopenia, can start from a lower dose or use erythropoietin concomitantly. And there is a risk of reactivation of latent infections. And response is monitored with reduction of spleen size and symptoms compared to toxicity. Disease symptoms and splenomegaly will recur on drug withdrawal. So gradual dose tapering is recommended and sudden interruptions are not recommended. This is another treatment algorithm which is based on MIPS 70 plus version 2 risk stratification method, but these treatment methods are difficult to apply in our settings. This is another treatment algorithm using GIP score. And these are our references. And this brings to end of the presentations of Candy and Peradeniya cluster. And over to you, madam. Thank you.
Thank you, Dr. Chamari and Dr. Kilini, for your excellent presentation and also enlightening us that we have to think about someone who is presenting with an unexplained anemia, though they don't have a splenomegaly, just the differential diagnosis of primary myelofibrosis. So that's really interesting to know that. And if you have any questions, can you please type on the chat box, so you can ask now. So this is a time we have left with for 3-4 minutes for questions from audience. It seems that there is no question from audience. So everybody understood, or they have not understood anything at all. So if you have any questions, please post in the chat box so we can take up those questions at the end. We'll move on to the presentations from next cluster. So here we are having gold cluster. There will be 2 presentations, and the first presentation will be on the misnomer mysterious killer, APLS, the antiphospholipid syndrome. Will be presented by Dr. KLGS Kaushalya, who is a diploma trainee in clinical hematology attached to Teaching Hospital Karapitiya, and Dr. DS Jayavikrama, who is a senior registered Registrar in Clinical Hematology. She's also attached to Teaching Hospital, Karapitiya. And over to you, both of you all, for your presentation.
Good morning, all. Today we are going to discuss about antiphospholipid syndrome, the misnomed mysterious killer. Our patient is Mrs. I, 36-year-old female, who is diagnosed patient with young hypertension and proteinuria on nephrology clinic follow-up with a history of pregnancy morbidity, referred to hematology unit for further evaluation of asymptomatic central retinal artery occlusion, detected during routine checkup. She was apparently well, no change in vision or red eye, no past history suggestive of any venous or arterial thrombosis or bleeding. She was not on any hormonal contraceptives containing estrogen. She denied any history suggestive of autoimmune rheumatic disorders like SLE, rheumatoid arthritis. She was diagnosed to have young hypertension on further evaluation and medical clinic follow-up. No other vascular risk factors like diabetes mellitus or dyslipidemia. No family history of thrombosis. Her past obstetric history was complicated with 2 first trimester miscarriages and 1 second trimester miscarriages and IUD at 3rd trimester. And the autopsy showed morphologically normal fetus. On examination, she was afebrile, not pale, not icteric, no rashes including photosensitive rashes, no peripheral stigmata of SLE like alopecia, oral ulcers, and arthritis, no lymphadenopathy or no hepatosplenomegaly. Investigations, full blood count and blood picture both revealed moderate thrombocytopenia only. Otherwise, renal functions, serum creatinine was high with value of 129 micromoles per liter and eGFR is 48 and in the CKD stage 3. Urine protein to creatinine ratio was in the nephrotic range with value of 493. Liver functions were normal and ESR is 56 millimeters in the first hour. ANA, DNA both were negative. Rheumatoid factor was not done. Ultrasound scan of the abdomen showed early renal parenchymal disease. No hepatosplenomegaly. Hams and Sickling tests were negative. Fibrinogen level test was not done. Calculation screening, INR was normal with value of 1.14. APTT, it was prolonged with 62 seconds. So we proceed with mixing studies. Immediate mixing studies showed 56 seconds, which was not corrected. And after 2 hours of incubation, it was not corrected. So time and temperature dependent inhibitors are excluded. So we proceed with DRVVT, which was moderately positive, and it was repeated after 3 months. And it was also positive. Anticardiolipin and anti-beta-2 glycoprotein both were negative. So these are the diagnostic criteria of antiphospholipid syndrome. So there are clinical and laboratory criteria. Our patient has both. So as clinical criteria, she had pregnancy morbidities and also this time arterial thrombosis. She has laboratory criteria. So she has lupus persistently positive lupus anticoagulant. Now I am going to discuss a little bit about the antiphospholipid syndrome. Antiphospholipid syndrome is an acquired autoimmune thrombophilic condition characterized by vascular thrombosis, and or pregnancy loss or morbidity in association with persistent positivity of autoantibodies known as antiphospholipid antibodies. There are three types. Primary antiphospholipid syndrome, when it is not associated with other factors. And the other one is secondary antiphospholipid syndrome, and it is associated with autoimmune disorders like SLE, rheumatoid arthritis, infections like syphilis, HIV, and drugs. Catastrophic antiphospholipid syndrome is the other type. Pathogenesis of antiphospholipid syndrome is not well understood. There are mainly three antibodies: lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein. Two-hit theory was described. First hit was the antiphospholipid antibodies are persistently present in circulation. Second hit is the thrombotic events occur following a trigger like infection, endothelial injury, inflammation. So, antiphospholipid antibodies bind to the phospholipids via antiphospholipid binding proteins, mainly the beta-2 glycoprotein 1. Beta-2 glycoprotein has 5 domains, 1 to 5, and also it has 2 confrontations, open, which is the active form, and the closed, which is the inactive form. In normal people, in the presence of phospholipids, it becomes activated, but it immediately converts to closed confrontation. But in the presence of antiphospholipid antibodies, it stabilizes in the open confrontation. So this antiphospholipid beta-2 glycoprotein 1 complex activate complement via classical path. So it produces C3A, C5A, which are potent anaphylatoxins that activate endothelial cells and increase endothelial permeability. And also it forms membrane attack complexes on endothelial cells and placental cells, leading to cell lysis and cell injury. So this activation of complement leads to a prothrombotic state. Further, antiphospholipid beta-2 glycoprotein 1 complex bind to various cell receptors on platelets, endothelial cells, monocytes, and neutrophils. Leading to activation of these cells leads to prothrombotic state. This is what I described earlier. So this activation of complement system produces different anaphylatoxins and form membrane attack complexes, leading to cell injury. Pathogenesis of pregnancy complications in antiphospholipid syndrome. There are several mechanisms described. First one is the complement activation, which leads to placental injury via inflammatory response and formation of membrane attack complex, leading to early fetal loss of growth restriction, and also intraplacental thrombosis. Inflammation, which leads to cell lysis and injury, interfere with annexin 5 function, and also inhibition of trophoblast differentiation and defective placentation. All these mechanisms leads to pregnancy complications. Antiphospholipid syndrome is a multisystemic disease. So patients can present with different clinical features. Even though in criteria, thrombotic only describe about thrombotic and pregnancy morbidity, but there are other clinical associations. They can present with symptoms of cardiovascular system, like valvular heart disease, Libmart sac endocarditis, and central nervous system symptoms like migraine, chorea, cognitive impairment, and renal nephropathy. Hematological manifestations like thrombocytopenia, hemolytic anemia. Cutaneous manifestations like livedo-reticularis and splinter hemorrhages. Dr. Dinosha will discuss about the management of antiphospholipid syndrome. Thank you.
Thank you, Dr. Sachini. Good morning, everyone. Dr. Sachini has given you a nice description about diagnosis, clinical presentation, and pathogenesis of antiphospholipid syndrome. I'm going to talk to you about the management of APLS. First of all, APLS is a complex multisystem disorder which should be managed with the collaboration of several medical specialties. I'm going to talk a bit about 2019 EULA recommendations for the management of APLS. However, some of these recommendations are based on weak evidence. Therefore, individualized plan is very important. EULA body has divided to talk about APL profiles. They have divided according to the antiphospholipid antibody type and the titer the patient's APL profile into high risk and low risk. Persistent positivity of lupus anticoagulant, double positivity of any combination of antiphospholipid antibodies, triple positivity, and persistent high antiphospholipid titers are called high risk group, high risk APL profile, and low risk APL profile is anticardiolipin antibodies, single presence or anti-beta-2 glycoprotein in medium or low titers. Asymptomatic patients with, let's talk about asymptomatic patients with APL positivity. If they have high risk profile, they recommend low dose aspirin, 75 to 100 milligram a day. But the patient is having low risk profile without any symptoms, there are no recommendation. If the patient is having high risk profile with SLE, systemic lupus erythematosus, lupus, again, low dose aspirin is recommended. But if it is low risk profile, we should assess individually patients' other vascular risk factors and consider low dose aspirin. If the patient is having, if they are having venous thrombosis with APLS, as we all know, anticoagulation is the main treatment, mainstay of management, with which is vitamin K with vitamin K antagonist with a target range of target INR of 2 to 3. Duration, if it is unprovoked thrombosis, it should be indefinite, long-term anticoagulation. However, if it is definitely provoked DVT, that should be again individualized plan. If the patient is having low risk APL profile, what EULAR recommendation is 3 months is adequate. However, if the patient is having other risk factors, consider long-term anticoagulation. DOACs are not recommended in APLS, however, can consider in patients with contraindication to vitamin K antagonist or not able to achieve target INR with vitamin K antagonist. Triple positive antiphospholipid syndrome, DOACs are not recommended. There's a recent randomized control trial to assess the efficacy of warfarin and rivaroxaban, which was done in triple positive APLS patients, which was terminated prematurely due to high risk of recurrence. Therefore, rivaroxaban is definitely no for triple positive APLS. Recurrent thrombosis with vitamin K antagonists, if the patient is in INR of target range, the options are either at low dose aspirin or increase target INR to 3 to 4 or change the patient to low molecular weight heparin. If the patient is having arterial thrombosis, generally we know arterial thrombosis, we consider aspirin only. If the but patients with antiphospholipid syndrome, they have very high risk of recurrence compared to venous thrombosis and tendency to thrombosis in the same vascular bed. Therefore, vitamin K antagonist is indicated with INR of 2 to 3 or 3 to 4. However, pooled data from 2 randomized control trials and 2 retrospective studies have shown there is no statistically significant difference between 2 INR groups. And DOAC is definitely not recommended in APLS with arterial thrombosis due to increased risk of relapse. If the patient is having recurrent arterial thrombosis, they should be evaluated for other risk factors, especially vascular risk factors, and low dose aspirin or increase target INR to 3 to 4 or switch to low molecular weight heparin are indicated. Refractory APLS, if the patient is persistently having thrombosis despite anticoagulation, options are hydroxychloroquine, low dose prednisolone, intravenous immunoglobulin or rituximab. Bit about obstetric APLS. If a patient is having APLS antiphospholipid antibody without any symptoms, low dose aspirin is indicated. If the patient is having recurrent fetal loss with or without SLE, low dose aspirin prior to conception should be given, and prophylactic dose low molecular weight heparin or unfractionated heparin should be given once pregnancy confirmed and postpartum 6 weeks. If the patient is having if her obstetric history is complicated with preterm delivery, preeclampsia or placental insufficiency, low dose aspirin alone or low dose aspirin with heparin should be given. And if the patient is non-criteria obstetric APLS, you all know that there are only 3 criteria in APLS diagnostic criteria, but patients may have other criteria like 2 first trimester miscarriages. In that type of case, low dose aspirin alone or low dose aspirin and heparin can be given. If the patient is having thrombosis with APLS, they should be definitely on therapeutic dose low molecular weight heparin or unfractionated heparin with aspirin. Persistent obstetric APLS despite treatment, again, as I earlier mentioned, hydroxychloroquine, low dose prednisolone or IVIG can be given. Catastrophic APLS, which is a life-threatening rare form of APLS, characterized by widespread thrombosis, which may lead to multi-organ failure over a short period of time. The precipitating factors are anticoagulant discontinuation, abrupt discontinuation, infection, and surgery. Combination treatment with glucocorticoids, heparin, plasma exchange, and IVIG are the mainstay of treatment with supportive care. Concurrent treatment of precipitating causes should be treated with antibiotics or surgical measures accordingly. Refractory catastrophic APLS, B-cell depletion with rituximab or complement inhibition with eculizumab can be considered. And as our Dr. Sachini mentioned, thrombosis and pregnancy morbidity are the hallmark of APLS, but they can have a lot of other complications like nephropathy, cardiac complications, respiratory complications. Those things should be managed accordingly with the relevant specialties. However, the cardiac complications, respiratory if the patient is not symptomatic, there's no indication for routine screening. Modifiable risk factors like smoking, obesity, estrogen-containing oral contraceptive pills should be advised, and the patient should be educated. And bit about our topic, misnomer. You know, lupus anticoagulant, as you all know, lupus is initially it was named as lupus because they thought it is associated with only SLE. However, it was later identified not there is primary SLE and there is association with other diseases also. So it is a misnomer, and it is an anticoagulant as it binds with phospholipid in vitro. However, in vivo, it is a procoagulant. So it is definitely a misnomer. And it's a mysterious killer because the pathogenesis is not well identified and it can kill the patient. Bit about our patient, she's 36 years, a young female with P4 C node. She with pregnancy morbidity and arterial thrombosis. She's a diagnosed patient with hypertension. Hypertension is a non-association with antiphospholipid syndrome, but the pathogenesis is still not well identified, which could be related to renal vascular thrombosis. And they can get malignant hypertension also. It is very important to control hypertension. She is having nephropathy and nephrotic range proteinuria, which should be more probably, which is due to thrombotic, the pathogenesis which is multifactorial, and it could be due to thrombotic microangiopathy or renovascular thrombosis, which should be managed with the collaboration of nephrology team. And experts suggest patients with nephropathy, APL-related nephropathy should be given anticoagulation also. And in our patient, we started her on anticoagulation, warfarin and low-dose aspirin long-term. Considering her other risk factors also, she was started on low-dose aspirin also, with a target range of, both for the warfarin, target range of 2 to 3. Avoidance of estrogen-containing oral contraceptive pills was considered, and she was screened for other vascular risk factors. She was educated and lifestyle modification was considered. And during her pregnancy, and her future pregnancy should be well planned with a multidisciplinary team, pediatrician, a neonatologist, obstetrician, pediatrician. And she was advised about the early conversion to low molecular weight heparin as she's on warfarin, which is petotoxic. And she should be followed nephrology. She should be continue her nephrology follow-up. That's all. Thank you.
Thank you, Dr. Sachini and Dr. Dinusha, for your excellent talk on APLS. And so we'll move on to our last case for the red box, and which will be again delivered by Gold Cluster to trainees from Teaching Hospital Karapitiya, Dr. Sandaru Vikramaratna, who is a diploma trainee in hematology, and Dr. J.C. Jayasinghe, who is a senior registrar in clinical hematology. Over to you, Sandaru and Janani.
Good morning, everyone. The second part of our our red box presentation is life with restrictions, an eye-opening case of intravascular hemolysis. So we are going to begin with a case-based discussion, and then we are thinking of moving to a little bit of theory part. So our patient is Master Y, a 5-year-old previously healthy child. And presented with fever, cough, and cold for 3 days, and episodes of dark urine for 1 day. And on day 3 of illness, this child was given a mixed salad of green leaves containing pupamania by his mother. And on the same day evening, child has developed abdominal pain, vomiting, and episodes of dark color urine. The color of urine resembled that of Coca-Cola color, but the urine output was good. The dark color persisted throughout the stream of urine. But there were no evidence of urinary tract infection such as dysuria, and there were no other bleeding manifestations and no history suggestive of aprocyanosis. And the parents denied any history of similar episodes in the past, and the child has not been on any medications. His birth history was uncomplicated, and there was no neonatal jaundice, and his past medical history was unremarkable. And his parents were non-consanguineous, and no family history of hematological or any other significant illnesses or similar presentations. And on examination, the general examination revealed severe pallor, mild icterus, and mild cyanosis in lips. But there was no aprocyanosis, no lymphadenopathy or skin rashes. And respiratory and cardiovascular system examination revealed oxygen saturation of 77% on room air, that was by pulse oximetry, and he was mildly dyspneic. Otherwise, his cardiovascular system examination was normal, other than mild tachycardia. His blood pressure was normal. And abdominal and central nervous system examinations were unremarkable. Then we proceeded with investigations, and his full blood count revealed a hemoglobin value of 7 grams per deciliter, and therefore he was severely anemic. And there was moderate neutrophil leukocytosis, and platelet count was normal. His blood picture revealed normochromic normocytic red blood cells with many contracted red cells, white cells, and some blister cells. Also, there was neutrophil leukocytosis with left shift and toxic changes, but there were no abnormal cells. And platelets were normally number and morphology. So, the morphological features were in favor of oxidant stress hemolysis with coexistent bacterial infection. So, this is a photograph of a blood film of this oxidant stress hemolysis, which contains contracted red cells, some white cells, and blister cells. Then we proceeded with hemolytic screening. His lactate dehydrogenase level was high, and it was 926 international units per liter. His direct antiglobulin test was negative, and there was indirect hyperbilirubinemia with the indirect bilirubin level of 62 millimoles per liter. And his urine hemoglobin was strongly positive, but urine hemosiderin was negative, and reticulocyte percentage was 8%. Serum hemoglobin levels were not done due to unavailability. And also we carried on with other investigations. His urine pool report was otherwise normal with no evidence of UTI, and also there was no bilirubinuria. His AST was mildly elevated, but ALT was normal, and CRP was 46 milligrams per liter. PTINR was normal, and also his serum creatinine level was also normal. And arterial blood gas analysis was done, and it revealed a partial pressure of arterial oxygen saturation of 199 mercury millimeters. So, depending on the clinical features and investigations, our differential diagnoses were oxidant stress induced intravascular hemolysis, probably due to G6PD deficiency, severe autoimmune hemolytic anemia, paroxysmal nocturnal hemoglobinuria, and paroxysmal cold hemoglobinuria. But PNH and PCH were down in the list, and due to characteristic peripheral blood film morphology and negative direct antiglobulin test,
Oxidant stress induced intravascular hemolysis, probably due to underlying G6PD deficiency, was our most probable diagnosis. So, when talking about the management of our patient, initial assessment was done and patient was stabilized. As child was hypoxic, oxygen 15 liters per minute via face mask was given, and IV fluid support was given with 2/3 of maintenance. And because of his severe anemia, 10 milliliters per kilogram blood transfusion was also given. And because of the child's hypoxic condition, child was transferred to pediatric intensive care unit, teaching hospital Karapadia for further management. And these are the problems identified at PICU. There was severe intravascular hemolysis following cupamania injection in the background of respiratory tract infection. And also child had severe hemoglobinuria, and also we suspected induced methemoglobinemia. So initially, supportive care was given, supplemental oxygen and IV fluid 100% maintenance with 10% deficit, and folic acid was given, and also another red cell transfusion was done. And in order to manage complications, renal functions, electrolytes, and acid-base status were regularly monitored, and we kept watch to see whether child goes into acute kidney injury. But fortunately, the child did not develop acute kidney injury, and the fluid balance was maintained. One significant thing that we noted was the gap between the oxygen saturation in pulse oximetry and arterial oxygen saturation in his ABG. The gap was significantly high. Therefore, methemoglobinemia was suspected. And methemoglobin level was done, and it was reported as 19%. As methylene blue cannot be given in suspected G6PD deficiency, child underwent exchange transfusion for correction of methemoglobinemia. Exchange transfusion was done with fresh frozen plasma and packed red blood cells, 70 milliliter per kilogram volume. And with one exchange transfusion, child's clinical condition markedly improved and subsequently achieved oxygen saturation of 97% on room air, and all his clinical parameters improved, and symptomatically also improved. And on follow-up management, upon clinical improvement, the child was discharged from the hospital. And parents were counseled regarding the diagnosis and to avoid triggering medications and food. And 3 months after discharge, child was reviewed at hematology clinic, teaching hospital Karapadia, and he was clinically well, and there were no morphological or biochemical evidence of ongoing hemolysis. Brewer's test, or the methemoglobin reduction test, was done as a screening test for G6PD deficiency, and it became positive. Child's brother was also screened with Brewer's test and screened negative for G6PD deficiency. So this is a photograph of samples of Brewer's test. This is negative control, this is the test sample, and this is the positive control. So as you can see, the sample of our patient, it didn't return to the original red color. Next, I'm going to discuss briefly about the child's clinical presentation, mainly focusing on G6PD deficiency. So, human red cells need protection against effects of free radicals to maintain red cell membrane integrity, and hemoglobin has to be maintained in its functional state, and steady production of methemoglobin should be reversed to deoxyhemoglobin, which binds oxygen. In red cells, the role of HMP shunt is the production of reducing power in the form of NADPH, and NADPH is needed for the production of reduced glutathione. Hemoglobin and red cell membranes are protected by oxidant stress by reduced glutathione, which maintain protein sulfhydryl groups in a reduced state. When oxidative stress exceeds the reducing power, acute intravascular hemolysis occurs, and also methemoglobinemia occurs. So this diagram shows how G6PD enzyme plays a major role in production of NADPH and thereby helps in producing reduced glutathione. So G6PD is the enzyme in pentose phosphate pathway which controls the flux through availability of NADP+. And the gene encoding for G6PD is located on X chromosome. G6PD deficiency is the most frequent defect in pentose phosphate pathway, and the complete inactivity of enzyme in nucleated cells would be lethal. The clinical consequences of G6PD deficiency are virtually confined to erythrocytes. And most of the mutations affect stability of enzyme, and the activity rapidly decline in mature red cells. Also, G6PD deficiency is the commonest genetically determined enzyme deficiency in world, affecting about 400 million people worldwide. And the variants are classified into 5 classes, and G6PD deficiency is widely disseminated throughout Africa, Mediterranean basin, Middle East, Southeast Asia, and indigenous populations of Indian subcontinent. And G6PD deficiency confers protection against falciparum malaria. There are four main clinical syndromes associated with G6PD deficiency, which are neonatal jaundice, favism, chronic non-spherocytic hemolytic anemia, and drug-induced hemolytic anemia. And G6PD deficiency is most common in males, but female homozygotes are also not uncommon. Heterozygous females are susceptible to oxidative stress because of X inactivation and extreme lionization. Then, when talking about the diagnosis of G6PD deficiency, indications for testing for G6PD deficiency include development of hemolysis after taking medications or experiencing conditions that can induce oxidant stress such as infections, unexplained or prolonged neonatal hyperbilirubinemia, non-spherocytic hemolytic anemia, hemoglobinuria, and prior to treatment with certain antimalarial and oxidant drugs such as Dapsone, and when red cell morphology is suggestive of oxidant stress hemolysis, and also when there is family history of G6PD deficiency. The investigations for the diagnosis of G6PD deficiency include the investigations to confirm hemolysis and screening investigations and confirmatory investigations. Investigations to confirm hemolysis are full blood count. Usually there is severe normochromic normocytic anemia, which is present during episodes of acute hemolysis. White cell count is normal unless hemolysis is precipitated by an infection, and platelets are normal. In the peripheral blood film, in most patients with G6PD deficiency, blood film is normal except during hemolytic episodes. During the hemolytic episode, the morphological abnormalities are very characteristic. There are irregularly contracted red cells, bile cells, and blister cells, some spherocytes, Heinz bodies, polychromasia, and also neutrophil leukocytosis can sometimes be seen at the height of hemolysis. LDH levels are raised. There is unconjugated hyperbilirubinemia due to hemolysis. Serum haptoglobin levels are markedly low, and urine analysis shows hemoglobinuria and urine hemosiderin. There is presence of urine hemosiderin due to severe intravascular hemolysis. And the screening tests for G6PD deficiency are the commonly used tests are methemoglobin reduction test for the Brewer's test and fluorescence screening test for G6PD deficiency. What we do in Brewer's test is the little bit of theory behind Brewer's test is hemoglobin contains ferrous ions, and in intact red cells it's converted to methemoglobin by addition of sodium nitrite. So methemoglobin contains ferric ions, and reversal of ferric ions to ferrous ions depends on the G6PD activity in red cells. So G6PD normal red blood samples will turn back to bright red, whereas G6PD deficient samples will stay brown. And when talking about confirmatory tests, quantitative analysis of red cell G6PD enzyme activity is the gold standard for the diagnosis of G6PD deficiency, and it's a spectrophotometric analysis. The testing for enzyme activity should be performed when patients are in remission, as results may be falsely negative during acute hemolysis. And when talking about management of G6PD deficiency, most individuals with G6PD deficiency do not require treatment. And the management consists of prevention of acute hemolytic episodes and management of hemolytic episodes and their complications. So, prevention of hemolytic episodes should be done by advising patients to avoid foods and drugs that can cause oxidant stress. Also, prompt and proper care for early care for infections should also be advised. And management of hemolytic episodes is usually supportive. Most patients recover spontaneously and need only monitoring. So we have to discontinue the offending stressor, most commonly a medication. If there's severe anemia or when there's a rapid decline in hemoglobin, red cell transfusion is life-saving. And supplementary oxygen should be given depending on oxygen saturation. Proper hydration is critical during acute crisis in order to prevent hypovolemic shock and also acute renal failure. And concurrent infections should be appropriately treated. When talking about possible complications, the main two possible complications are acute kidney injury and methemoglobinuria. Acute kidney injury occurs due to hemoglobinuria and when there is hypovolemic shock. Monitoring of renal function, electrolyte balance, and acid-base status should be done, and correction of fluid balance, electrolyte, and acid-base abnormalities should be appropriately done. And methemoglobinemia in G6PD deficiency is an important complication, and the management differs from that of the management of normal routine methemoglobinemia. And Dr. Janani will discuss about the management of methemoglobinemia. Thank you.
Thank you, Dr. Sandaru. Good morning, everyone. So today I'm going to discuss about a little bit about methemoglobinemia, as our patient also having this condition. So methemoglobin is an oxidized form of hemoglobin. It contains ferric ion and has high affinity for oxygen, and it's shifting oxygen dissociation curve to left. So spontaneous production of methemoglobin is neutralized by NADPH, methemoglobin reductase pathway, and many other minor pathways. So methemoglobinemia is a rare disorder associated with oxidization of divalent ferroion of hemoglobin to ferric ion of methemoglobin. It is characterized by presence of more than 1% of methemoglobin in blood. The presence of iron in the ferric form state resulting in binding of oxygen irreversibly. Therefore, it shifts the oxygen dissociation curve to the left. This shift further leads to increased affinity of ferrous ion for oxygen. Thus, impaired oxygen release to the tissues, resulting in tissue hypoxia with the so-called functional anemia without HB decrease. So, methemoglobinemia can result from either inherited or acquired processes. So, acquired forms are the most common, mainly due to the exposure to substances that cause oxidation of the hemoglobin. The inherited forms are due to either autosomal recessive variants in the cytochrome gene system or to autosomal dominant variants in the globin genes. Collectively, they are known as hemoglobin M disease. So these are the clinical features of a patient with methemoglobinemia. So that the clinical features are depending on the level of methemoglobin. If the patient is having less than 10% of methemoglobin in blood, so they are frequently asymptomatic, but occasionally they can present with gray skin discoloration. If the methemoglobin level is 10 to 20%, so they can present with cyanosis, and if 20 to 30%, only they develop dyspnea, headache, and anxiety. Further increase with hemoglobin levels, they can present with at level of 30 to 50%, dizziness, palpitation, confusion, and tachypnea. So in the range around 50 to 70%, they present with severe symptoms, seizures, cardiac arrhythmias, metabolic acidosis, and even coma. And usually, patient present with more than 70%, they can result in death. So diagnosis, when considering the diagnosis of methemoglobinemia, if when to suspect this, one thing, if patient is having known family history, and the second thing, sometimes the incidental finding of increased methemoglobin in arterial blood gas or venous blood gas, when we do it for other reason. The third one is saturation gap between pulse oximetry, such SpO2, and ABG oxygen saturation. This occurs because methemoglobin usually in patient with methemoglobinemia, pulse oximetry SpO2 is reduced and ABG is normal. So this, why this happens is methemoglobin have modified light absorption pattern. So most pulse oximeters give fixed value around 85%. As well, methemoglobin falsely increase the calculated oxygen saturation in ABG. So ABG measured value, because they measured in ABG, is plasma oxygen, which can be normal in methemoglobinemia. So saturation gap of these two more than 5% indicate the presence of methemoglobin. The other specific test that for the measurement of methemoglobin is that principally and behind this test is methemoglobin has a maximum absorption at 630 nanometers. When cyanide is added, this absorption band disappears, and the resultant change in the absorption is directly proportionate to the methemoglobin concentration. So methemoglobin can be expressed as a percentage. Is calculated by dividing the concentration of methemoglobin and by divided by the concentration of total hemoglobin. So with regard to the management of methemoglobinemia, for acute management, the distinction between hereditary or acquired is not important. The treatment indication usually depending on the level of methemoglobin. So treatment should be considered in methemoglobin 30% at around 30% in asymptomatic patients and in 20% in symptomatic patients. For hereditary cases, they tolerate more higher levels like 30 to 40% of methemoglobin. If additional risk factors are present that compromising oxygen delivery like COPD or cardiac diseases, they need treatment at lower thresholds. So other generalized management include the avoid exposure of the offending agent and supportive therapy, including IV hydration and oxygen supplementation, and adequate glucose to form NADPH via hexose monophosphate pump is also very important in this setting. With regard to the methylene blue, it is a primary treatment. It acts by accepting an electron from NADPH and it's convert into the leucomethylene blue, which act to reduce the Fe3 plus back to the Fe2 plus. So starting dose of IV methylene blue 1 to 2 milligram per kg infused over 3 to 5 minutes. The dose may be repeated at 1 milligram per kg if not significant methemoglobin levels are not significantly decreased within 30 to 60 minutes. Usually the reduction of methemoglobin can be seen within 1 hour of methemoglobin infusion. So this is the methemoglobin reduction pathway. You can appreciate here that when we give methemoglobin, it uses this NADPH to become NADP plus, and methylene blue is converted to leucomethylene blue. Then this leucomethylene blue is the substance that again become methylene blue, and Fe3 plus in methemoglobin become Fe2 plus. But there is a problem with methylene blue. It can cause rebound methemoglobinemia, and it also increases the risk of hemolysis in G6PD deficient patients, because this is the main problem with our patient. So there is an increased risk of hemolysis in our patient if we give methylene blue to our patient. The reason for that paradoxically, methylene blue is an oxidant. its metabolic product, that leukomethylene, is the reducing agent. So large doses may result in proportionately higher levels of oxidizing agent, methylene blue, rather than the reducing agent. So methylene blue may induce hemolysis, acting as an oxidant, and paradoxically it worsens methemoglobinemia in the patient with G6PD deficiency. As well, there is other reason for this aggravation of hemolysis in G6PD deficiency, where if we give methylene blue. In addition, because G6PD deficiency is the first enzyme in the hexose monophosphate shunt, the only source of NADPH in the erythrocyte is the G6PD enzyme. So patients with G6PD deficiency may not produce sufficient NADPH to reduce methylene blue to leukomethylene blue. Therefore, methylene blue therapy may be ineffective in the G6PD patients with methemoglobinemia. So in these patients, alternative treatments such as ascorbic acid, or in severe cases, extended transfusion should be considered. Methylene blue should be avoided in patients with G6PD deficiency, and ideally all patients should be tested for G6PD deficiency before giving methylene blue. So there are a place for red cell exchange transfusion in methemoglobinemia, where methylene blue is contraindicated, as in our patient, or where the patient is not responding to methylene blue. So with regard to the other patient, we get down the patient at the clinic and advise regarding the avoidance of precipitating drugs or substances, and advice on seek early advices if features of hemolysis, and arrange regular follow-up at hematology clinic. So take-home message is methylene blue cures the cyanosis in methemoglobinemia, but cautious about the presence of accompanying G6PD deficiency, which can be potentially hazardous to the condition of the patient, causing excessive hemolysis. Therefore, in any patient presenting with methemoglobinemia associated with severe hemolytic anemia, as in our patient, it is desirable to check G6PD activity before giving methylene blue. These are our references for the discussion part. This is the end of our presentation from Goal Cluster. Thank you very much for
Thank you, Dr. Sandharu and Dr. Janani, for nice talk on methemoglobinemia and G6PD deficiency. Can I just quickly ask, have you all done G6PD level on this child activity?
No, madam, G6PD levels have not done. Patient cannot afford. Actually, we have only done the Brewer's test.
Okay, so Brewer's test usually you all don't do at the time of acute hemolysis, isn't it?
Yes, madam. That patient came 3 months back to the ward, but we got down the patient after 3 months of the acute hemolysis and do the G6PD assays. Brewer's test.
Okay, so because the take-home message that you have mentioned, if someone is presenting this methemoglobinemia, so before you giving a methylene blue, ideally speaking, we have to rule out the G6PD deficiency. Am I right?
Yes, madam. That can we have to rule out.
Yeah. So how can we rule out the G6PD deficiency?
Yes, that madam, only that we can ask for the family history. And those things we can ask from at the presentation. And on clinical suspicion, if the family history is positive, we can ask for that. So at the acute hemolysis, we can do the Brewer's test.
Yeah, of course, we can't do it. And of course, sometimes like even the G6PD level can be false positive, isn't it? Like if during the acute hemolysis, if the reticulocyte count is high, then you expect activity also should be normal, isn't it? So this is a bit tricky, isn't it? Like how can you rule out the G6PD before you giving methylene blue, someone suspecting to having methemoglobinemia, isn't it? So so I also don't know how to actually rule out that, but one thing would be the family history, yes, that you can, and maybe suggestive, and you might be cautious in someone who is having a family history, and or someone who is already diagnosed patient with G6PD deficiency. Of course, you have to avoid giving a methylene blue. And And you have mentioned that in case if we can't give a methylene blue for methemoglobinemia, so there are options would be to go for the red cell exchange transfusions. So is there any cutoff level for methemoglobin levels? Is there any cutoff level, or is that the same applicable for a cutoff?
No, madam, they just mentioned in that same cutoff level as the exchange transfer. When we cannot give methylene blue, so that's one indication for start plasma exchange. But the recent ASH blood articles also, they won't give an account on that level of level to start blood cell exchange transfusions, madam. This recent one that blood article that they reveal management of methemoglobinemia.
Okay, so there's no cutoff such.
No, madam.
Yeah, so you so basically, if usually we go for the methylene blue cutoff level to decide if whether methemoglobin level cutoff level to decide if whether the patient needs methylene blue or not. So that of course you have described in your presentation the asymptomatic patient and symptomatic patients and what are the levels and how they present it, and when you will decide that patient needs treatment for methemoglobin. For the red cell exchange transfusion, of course, the patient who needs methylene blue, where we can't give methylene blue, of course, you have to think about giving a exchange transfusion, isn't it? Yeah. Yes. So
another thing, madam, in our patient, we thought that because blood picture is suggestive of G6PD deficiency. That's why we didn't give methylene blue in our patient.
Okay, but the cutoff is, you said 19%, isn't it? Like in your patient.
Yeah, our patient 19%, madam. Cutoff I have described that 20%
yes.
In symptomatic and 30%. Yes.
Yes, so sometimes we can't really stick to the level also, cutoff levels.
Yes,
also.
yes.
If clinically severe, then of course you don't for the cutoff. And can I just know how much the cost for the methemoglobin level to be done in Sri Lanka? How much the test, because of course we don't have it in state sector, so we have to get it done in the private sector. How much the cost for the test?
We have done the methemoglobin levels here, madam.
Where in your goal?
Yes, madam. That we add that to the sample, we add cyanide, and that all the hemoglobin is reduced. Then we can calculate the levels. And the next sample, another sample, we add the potassium cyanide, that it convert all the hemoglobin to the methemoglobin. So the difference is the divided. The top is the methemoglobin, and the lower one is hemoglobin level.
Okay, so you said that it is done at your hospital.
Yes, madam.
Okay, so there was a message at chat box also saying that test has been done at MRI too. So we can get it done if we need it, like so in emergency cases where we actually want to know the methemoglobin level.
Yes. We also did once very recently, 3 months back in the hospital, but it is the first time. Yeah.
Actually, Dr. Jennifer, yes, I heard about from actually the Kalabovla, there was a patient, isn't it? Like it methemoglobin.
Yeah. We did at hospital, but because it's the first time we did methemoglobin levels, we sent to the private sector also.
Exactly.
That both came as
tally your results.
Results matching. The cost is around 3,500 or something. Not high, less than 5,000. I mean.
Okay, very good. At least we have less expensive test, isn't it? Like reasonable price, like 3,500. Okay, so nice. So it's an excellent presentation by Dr. Janani and Dr. Sandaru. So it was really a nice thing. It really enlightened us that how to manage, and we have to be cautious if someone who is having a G6PD deficiency presenting with methemoglobinemia. And thank you for sharing this case. So that is actually concluding the red box presentations for the day today. And we will be moving to Young Hematologist Forum. So here we have 2 young hematologists with us today to share their experience that they have acquired during their overseas training, and also they just wanted to compare some, so giving some examples of cases where they have experience in overseas as well as here, and how to just to compare and just to enlighten us that. So here today we have Dr. Chamindi Jayasundara and Dr. Thamutika Vidanage. So Dr. Chamindi Jayasundara will be presenting first case-based discussion on acute myeloid leukemia, diversity in patient management. So she is an acting consultant clinical hematologist at District General Hospital, Vaunia. Over to you, Dr. Chamindi.
Thank you, Dr. Ahalya. Thank you for organizing everything, and thank you, the Sri Lanka College of Hematologists as well, for the opportunity given. I will start sharing my screen now. Dr. Ahalya, can you hear me all right?
Yes, Chamindi, please go ahead.
And the screen is okay?
Yes, Chamindi, yes.
Okay, so yeah, as I mentioned, thank you so much once again. I'm Chamindi Jayasundara, acting consultant hematologist, currently working in District General Hospital, Vaunia. I would like to share some of the experience from my overseas training in UK. So I thought of discussing about AML, the diversity in patient management, which I experienced there. A bit unfamiliar topic to us, maybe not so unfamiliar with regards to diagnosis, but mainly with regard to management. So thought of, because it is a place where they have all the diagnostic and therapeutic facilities rather than what we have here, I thought I will discuss some of the cases which I encountered and bit of theory behind it. So how the patients can get referred to us, the initial kind of considerations can be as the same as here. So urgent referral, maybe you're the on-call registrar, and maybe the call is for the on-call hematologist. The reason for the referral would be a high white cell count, cytopenia, maybe a patient with this high count or cytopenia coming with certain symptoms, where the suspicion is acute leukemia. Or the laboratory is giving you a call saying there's a flagging with high white cell count or high monocyte count, or there are atypical cells which they have discovered in the blood picture. Then we have to guide the management. Maybe you are the first contact person who's taking this call. If it is a doctor or a clinical person calling to you, you should guide them regarding the diagnosis as well as initial stabilization of the patient. We are still only suspecting a leukemia. So immediate arrangement for a blood picture, and depending on the blood picture findings, proceed with a bone marrow aspiration and a biopsy and certain other blood investigations, which we will discuss in a minute. So just not only the diagnosis, then and there we'll have to get a bit of a history, because the suspicion, background suspicion, is acute leukemia. Ask how the patient is. Does the patient have a fever? Is the patient neutropenic, or is the patient well or unwell? That is a very important thing, because you will advise then and there to start on broad spectrum antibiotics to prevent a neutropenic sepsis and a patient deteriorating at that time. And does the patient have features of leukocytosis? A high white cell count should alert you to that, thereby thinking of tumor lysis syndrome. Then and there you can ask them to do the certain investigations regarding that. And whether the patient needs a blood transfusion, severely anemic patient or patient with bleeding. So arrange the transfusion, and once the diagnosis is established, further investigations, including excluding a pregnancy in a female, is very important. So the diagnosis, blood picture and morphology is something every one of us are very capable of doing. Therefore, I don't want to elaborate much on that, because that is one of our strengths. Even when we are in our foreign training, overseas training, they are really respecting us with regards to our morphology. But the one thing I noticed is what they are really concerned in looking at a blood picture. Once they see the abnormal cells, the concern is whether it's an acute leukemia or a lymphoma. Are we thinking of acute leukemia, then whether it's acute myeloid leukemia or acute lymphoblastic leukemia? If it is a AML, they are not really worried about the rest of the classification, like the FAB classification also. What they are worried about is whether it's a APML or not, because the management of APML would differ from that of AML. So the first question or the first concern they have, whether it's an acute promyelocytic leukemia, APML. So urgently they would act for the further investigations, as well as try to stabilize the patient with starting immediate treatment. In case it is a blood picture with acute promyelocytic leukemia, it's an emergency. You should plan the further investigations, a bone marrow biopsy, and your PML, RARA, and all those things for the diagnostic purpose, and then and there get the treatment ready. When there was one patient with this suspicion, my consultant, the advice was personally attend to the patient, make sure the ATRA is prescribed, or the chemotherapy is prescribed, the pharmacy is informed, and the patient receives the first dose of treatment then and there. So this patient is your most prioritized patient. So better to personally handle and make sure that the patient is receiving the first doses. Okay, so a bit about bone marrow aspiration and biopsy. Again, bread and butter to our trainees. Nothing much to mention about the procedure. Just to mention, patient identification is very, very important. Make sure you yourself identify the patient. Make sure the patient's the number is tallying, at least 2 identifiers are tallying. Go to the patient, explain the procedure, and take an informed written consent. These are very important for your safety and the patient's safety. The bone marrow biopsies may be done in a routine manner with a list where they have a dedicated place or dedicated person, a healthcare assistant to help you, and you are the person doing the bone marrow. Or maybe it's an urgent bone marrow biopsy where you will have to go to the patient in a ward. It might not be your hematology board. If it's an urgent bone marrow biopsy, you will be the one performing the bone marrow biopsy. So make sure the safety protocols are done correctly. So once the formalities are done, then the procedure and the samples are collected. Each and every trust in the UK will have their own ways of doing. Some places will be you will have the dedicated staff and the place for the biopsy, and some places you will be the person doing everything. The trust I was working, there were facilities for us to carry out the bone marrow biopsies with the help of the others, like the healthcare assistant, and everyone was there for the supportive thing. So the samples, morphological sample, and sometimes the slides are made then and there. In our trust, it was an EDTA sample which we collected and sent to the lab. Then the flow cytometry, the guidelines recommend the first full sample to use for that, because otherwise the next samples might get too diluted. Then your cytogenetics, each and every patient get this investigation done. the heparin sample, and according to your trust policy, whether extra samples are needed, whether samples are sent to different centers for certain investigations like a FLIC3 mutation, NPM1 mutation, and whether there are ongoing trials. This is one thing we might not be aware in the beginning. If there are trials samples taken, there's usually a separate consenting procedure. You might not be able to consent the patients for trials initially unless you do your training and get signed off for that, like obtaining trial samples, or maybe a consent from another person is needed to obtain these kind of samples. So labeling and making sure that these are delivered to the correct place. These are small practical points which might be helpful to you all during your overseas training. So because I thought I don't need to insult the diagnostic procedure up to this point, because morphology is very good of everyone. So I'm not going to the morphological classification of diagnosis. I thought I will stress upon a bit on genetic tests, because at the moment we don't have facilities to do this. But as per the new ELN guideline, the latest, the 2022, or even the ones before, genetic testing is a mandatory test in diagnosis, as well as risk stratification, as well as monitoring a patient with acute myeloid leukemia. So once we have done the initial investigation, the patient suspected of AML, we have looked at the blood picture and a bone marrow biopsy was carried out. Looking at these slides, it is a confirmed AML. Now there's a waiting time. The patient will be immediately brought to the hematology ward, and the hematologist and the team will be attending to the patient. The initial wait for the patient is a difficult time because we need certain investigations to prove our diagnosis. Flow cytometry for one, and then of course the cytogenetics and molecular genetics before we can start the specific treatment, because treatment is guided mostly by these investigations. So at this point, it has to be a multidisciplinary kind of management. As I told before, always attending to symptomatic care, which is very, very, very important in managing these patients. And there's a special person called clinical nurse specialist, or the CNS in hematology. This role is a very, very important role. Once again, they provide so much of care to the patient regarding social, psychological aspects. They would attend to the fertility aspects, do the necessary referrals and counseling, or even if there's a HLA typing needed, bone marrow transplant, all those things were arranged by the wonderful CNS nurses in our trust at that time. So it will be a very good thing to have a good relationship with them so that everything is managed in a smooth manner. A patient with very high white cell count can be commenced on hydroxyurea to get the high count down. They say when the counts are very high, it's a very kind of, the patient can get bad, and you have to act quickly and make sure the white cell count is not going out of hand. And it might cause hyperleukocytosis, then clogging in all those endocrines and causing damage, and also tumor lysis syndrome, which is a very feared thing. The monitoring of tumor lysis bloods, as you all may know, we are monitoring the renal function especially, and then the electrolytes, the potassium, the calcium, the phosphate, the uric acid. If the counts are high, these blood tests will be monitored initially twice a day and then immediately. IV fluids, the input-output charts, and also things like allopurinol, all things need to be considered. Once the diagnosis is confirmed, there will be a MDT meeting to discuss the diagnosis, the treatment options, the bone marrow transplant plans, or any other trials available. There will be a session of breaking the bad news to the patient. The senior most person, the consultant, the registrar, and the team will attend. The clinical nurse specialist will also be there. And you will inform the diagnosis to the patient first, and with the consent of the patient, then to the family. Usually we have to speak to the family. In each and every trust, there will be like they will give a name or designated person as to who their family, the person of contact. And ideally, we can only break the news to this person they have designated as their kith and kin or the relative. But if we are to discuss anything, patient's details with any other relative, we need patient's consent again. And we have to give reading materials to the patient about acute myeloid leukemia, the treatment options, give some time for them to decide regarding the treatment options. And once they have received all the information, and after these discussions, the decisions are taken as to the type of chemotherapy which can be given or the specific treatment which should be followed, then the consenting for the chemotherapy, a consultant hematologist, or if you are the registrar will do the chemo consenting, which is again a very important. So the MDT discussion, as I told already, involves all aspects, discussions about best available care for the patient, and if there are trials, we have to think of these as well. And there will be plans about specific therapy or the chemotherapy. So in AML management, there are two broad cohorts of patients or categories of patients: the young and fit, who are fit to undergo extensive chemotherapy, and then not so young and not so fit to undergo extensive chemotherapy. This is done with the assessment of age, not like no real cutoff regarding age, 60 or even more than 60, the patient is able to tolerate the chemotherapy. Then the performance status, ECOG good performance status, and comorbidities are considered. And if the patient is decided to be a young and fit patient to undergo intensive chemotherapy, then the cytogenetics, molecular genetics, and their risk stratification is important in deciding further treatment options. So as we are aware, there's ELN guideline again with favorable, intermediate, and adverse categories of patients, like categorization of risk of disease based on cytogenetics, and now coming on other molecular genetics as well. So coming to the first case, try to apply the things which we have already discussed. A few cases, I'm not going to cover the whole theory behind each case, but maybe highlight some of the practical points which we have seen practically during our training, because we might not be experiencing firsthand these kind of scenarios during our day-to-day training in Sri Lanka. So case one was Mr. MM, previously healthy, very cheerful male. He was a Caucasian, 47-year-old, and he has presented to the GP 2 weeks back with the complaint of high fever and sore throat, treated with antibiotics for 2 weeks, no response. He was telling he was feeling extremely tired and never felt this feeling before. And the GP, after 2 weeks, decided to do the full blood count and a CRP. Remember, this was the time where the high peak of COVID, and it was difficult for the patient to get a doctor's appointment. So by the end of 2 weeks, when they did the full blood count, the WBC count was very high, 260,000, and the CRP was 109, in spite of the coamoxiclav treatment, which he had received almost about 10 days now. He was advised to get admitted immediately, and once admitted, due to this high count and abnormal cells, there was a call to the hematology department telling there's a suspicion of acute leukemia. So the diagnosis, immediately the blood picture was seen. the morphologically, there was a doubt between whether it's a AML with a monoblastic kind of picture or whether acute promyelocytic leukemia hypogranular variant. We ourselves saw the blood pictures and yeah, we also had the suspicion whether it's a APML. So it was a high, because of that suspicion, ATRA was initiated actually, but then it turned out to be, it's not an APML. High white cell count, leukostasis, cytoreduction done with hydroxyurea, again, hydration and monitoring of pneumonitis. Patient was started on broad spectrum antibiotics and the care was taken over by the hematology team. Patient transferred immediately to the hematology ward, because we can provide better overall care in our unit. So investigations done, flow cytometry, it was a CD33 positive AML. They were actually myeloblasts, and immunofluorescence for, APM, no evidence of atypical microgranular pattern. Sorry, the spelling mistake here. And then interface fish also did not show any evidence of PML-RARA rearrangement. Molecular genetics, FLT3 ITD positive with allelic ratio above 0.5, NPM1 positive. So it was a CD33 positive AML, ELN intermediate risk category. Why I have highlighted the CD33, FLT3 and these are because these have specific targeted therapy. So upfront treatment options for patients who are eligible for intensive chemotherapy, the treatment options would differ according to the certain genetic findings. AML with FLT3 mutation or AML without FLT3 mutation. If the patient is eligible for like upfront chemo, then daunorubicin and cytarabine will anyway be started, and then depending on FLT3 mutation, midostaurin, the FLT3 inhibitor, which is oral medication, can be started. If it's not a FLT3 mutated patient, the midostaurin will not be started. The other options are the GO or the Mylotarg, which is for CD33 positive, favorable or intermediate risk patients. But when the midostaurin is started, usually GO is not given simultaneously because the flow is available earlier. The CD33 positivity will be discovered early and patient might be started on GO. Later on, they will stop it and convert to midostaurin once the genetics are back. CPX is the other option where there is a myelodysplasia related changes. So intensive FLT3 positive NPM1 positive patient was treated with DA, we call it DA, the daunorubicin and cytarabine. Donor need to memorize the regimes by heart just to know the special things to think about when treating a patient. So what are the kind of side effects? The other thing is the patient will need a PICC line or a Hickman line, because these are vesicants which cannot be given from a peripheral line, and also baseline echo, ECG, to make sure that no cardiac problems, and also liver functions, renal functions, excluding pregnancy in females, all are needed before starting these regimes. Few specific things to mention. Daunorubicin has cardiac toxicity. A cumulative dose is there that has to be thought of. Then cytarabine can cause a thing called cytarabine syndrome about 6 to 12 hours after starting the treatment with fever, myalgia, arthralgia. Midostaurin, the FLT3 inhibitor, the QT interval is important, QT monitoring, and if the QT is more than 500, might have to withhold and restart treatment. And also need to think of other causes which QT interval can be prolonged, such as magnesium levels and electrolytes need to be looked into and corrected. And also certain antiemetics can cause this that need to be thought of. And when a patient is on high doses of cytarabine, there can be drug-induced conjunctivitis. So steroid eye drops are important. Other thing is supportive medications, the allopurinol, the antifungus, the antiviral, the cyclovir, proton pump inhibitors, and anti-MTs. So the patient had initial donor RSC, which was followed with the HIDAC, is the high dose RSC. I have used the shortened form as well because they will be referring in this manner, and sometimes in the notes also these documentation will be as HIDAC. IDAC like that, so we need to be a bit familiar with that. That's the reason why I have kept it there. And then in the end, patient had MRD negativity, and because intermediate risk, patient proceeded to have a allogenic stem cell transplantation, and up to now doing well. Case number 2 is a 66-year-old engineer, AML, myelodysplasia related changes, cytogenetics, a complex karyotype. What are the options now? There's a thing called the CPX or the Victios, which is specially given for the patients with therapy-related MDS or myelodysplasia related MDS. The side effect to think, CPX was started in 2 cycles were given to this patient. MRD low level positivity at end of 2 cycles. Therefore, the 3rd cycle of CPX or the Victios was given, and then intermediate dose cytarabine. So CPX or Victios is a combination drug, which is a liposomal derivative combination of daunorubicin and cytarabine. So when with all these medications, with daunorubicin actually, there's a side effect alopecia that also patients needs to be told before starting the treatment. The patient again was followed with allogenic stem cell transplant, as patient was in a high risk category, and again the patient is doing well with features of skin GVHD. Next patient is Mrs. TG, 63-year-old, good performance status, initially had 76% blast, CD33 positivity, FLT3 positivity, and initial chemotherapy was DA with midostaurin 4 cycles, achieved remission. Because of the intermediate risk category, patient was referred for the bone marrow transplant, but refused transplant at this point, later to relapse after 8 months. So now the patient, a fit patient who is fit for chemotherapy, has refused transplant and has relapsed. Now there's a place for salvage chemotherapy to get a remission. There are options. Gilteritinib or FLT3 inhibitor is one, and FLAG-IDA is another one. FLAG-IDA stands for fludarabine, then RSC, the GCSF, and idarubicin. The thing to know with FLAG-IDA, irradiated blood products are a must. Patient received fludarabine should be on lifelong irradiated blood products. Other thing with FLAG-IDA, idarubicin, the patient's urine may, the color may change. So the patient was given FLAG-IDA end of cycle 1. Again, there are persistent blasts. Then the FLT3 inhibitor, gilteritinib, was introduced. Achieved a remission, but recurrent infections, septic arthritis, multi-drug resistance, and eventually died 2 years after the initial diagnosis. A bit about elderly, not so fit for intensive chemotherapy patients. What are the options? Azacitidine subcut together with oral venetoclax, low dose cytarabine with venetoclax are the available options. Others could be in trial settings. So Mr. JL was a 72-year-old with good performance, again no comorbidities, with a karyotype of 46XY and a monosomy 7, FLT3 NPM negative. NGS showed the adverse ASXL1, TET2, DMMT, and KRAS. the MDT decision and the family discussion, the decision was he cannot undergo intensive chemotherapy like CPX, although the background dysplasia was there because of the age as well as high risk of infection and inability to tolerate intensive chemo. Therefore, as a cytidine subcut is given, usually we say 5+2, 5 days, Monday to Friday, give a break Saturday, Sunday, again Monday, Tuesday, another 2, and then with oral drug, venetoclax. Thing to know about venetoclax would be there are interactions of azoles, therefore there's a change in the doses with the days where azoles are there and not there, and the risk of tumor lysis, adequate hydration needed, and the monitoring is needed. He had multiple interactions to chemotherapy and with neutropenic sepsis. End of cycle 2, not achieved remission. Therefore, he could not tolerate even this regime because of recurrent infections, and he was transfusion dependent, severe thrombocytopenic. Therefore, decided to go for best supportive care. Palliative care team, the consultants and the team. He was managed with supportive care and ultimately died with neutropenic sepsis. I think this is the last. Again, a patient who was not fit for chemotherapy. She had diagnosed MDS in August 2020, who had undergone 10 cycles of azacitidine. Then the MDS had transformed to acute myeloid leukemia. And she could not tolerate the intensive chemo, therefore venetoclax with low dose araci-cytarabine or the same, and had to stop after 2 cycles because she could not tolerate as well palliative pathway and died after 3 months. So these are the approved treatment options. The other treatment options will have to be in trials only. The approved, apart from the dono-araci, others are the midostaurin, the FLT3 inhibitor, arsenic trioxide in APML setting, gamtosumab also gamsin. The CD33, when the patients are 33 positive, that option is there. CPX or the Victios for the patients with therapy-related or MDS-related disease. And the next line would be gilteritinib for the FLT3 mutated, or then the venetoclax again recommended, and unsuitable patients who are unsuitable for intensive chemotherapy. So coming to the end of it, this is complex. AML is complex and treatment options are diverse. I wanted to just give a glimpse to what we can expect or we can see and we can manage in our overseas training, and the treatment, how we should go about with patient care. Supportive treatment, mandatory, excluding APML, very important. Cytogenetics are very, very important for risk stratification, therapeutic decision-making, targeted therapy, as well as MRD monitoring. So one thing I couldn't mention, at end of each cycle, usually a bone marrow aspiration is done to assess the remission status, which will be through morphology as well as MRD monitoring by flow cytometry or the cytogenetics, whichever the marker they have detected at the beginning. To monitor for the MRD. Then the supportive care is paramount in patient care. Treatment decisions are according to the fitness and possibility of withstand chemotherapy as well as the genetic workup. Fertility issues, social, psychological factors, patient and family education, consenting for procedures as well as chemotherapy, optimum nursing care, disease monitoring, follow-up are vital in achieving a good outcome. These were the references, mainly the this year, the 2022 ELN guidelines. And thank you very much.
Thank you, Dr. Chamindy, for sharing with us a vast area of AML in a nutshell. Thank you once again. And if you have any questions that you can ask from Dr. Chamindy, or you can post the questions in the chat box. So we can wait.
Yeah, and sorry that the first or second years, it might have been a bit of like too many words and jargon, but hopefully for the MD and the senior registrars, and may have been some sort of a opener. Okay.
Yeah, so if you have any questions, you can ask from Dr. Chamindi now, or you can post the questions in the chat box. So if you have any questions, please post in the chat box. So since we are running short of time, we'll move into our next presentation on unfolding the story of a hidden killer, a case-based discussion on HLH by Dr. Thamutika P. Vidhanake. She is the acting consultant hematologist at Teaching Hospital Batticaloa. So over to you, Thamutika.
Am I audible?
Yes, Thamutika, proceed.
Right. Thank you. Thank you, Ahalya. Right. Hello, everybody. So my topic actually is based on two case presentations. And previously, there was an excellent speech by one of the speakers regarding HLH, hemophagocytic lymphohistiocytosis. So as they have in-depth analyzed the pathogenesis and the causes and also the diagnosis, I thought better to stick to the management issues and some dilemmas we might face when managing such patients to make my speech less boring. Right. So moving on to my first patient who I met during my overseas training period. At Royal Stoke University Hospital. She's a 57-year-old female patient who came with fever, high-grade fever, to the infectious diseases ward initially. This is a very, apparently healthy patient with well-controlled hypertension only. And on examination, she had hepatosplenomegaly and cervical lymphadenopathy. And on investigations, they have found pancytopenia. All the blood cultures and urine cultures were negative. Her liver and renal functions were deranged. There was a high LDH, and also the 2D echo was normal. ANA was negative, and CT tap, that is thoracoabdomen and pelvis, showed no evidence of malignancy. Because of the cervical lymphadenopathy, they have done a lymph node biopsy also, which was reactive. And then the serum ferritin came as 15,000 plus. So there was the suspicion whether this is hemophagocytic lymphohistiocytosis, and the patient was referred to us, hematology. We did the bone marrow, and as expected, there was evidence of hemophagocytosis without any evidence of malignancy. Serum fibrinogen was low in this patient to meet the criteria of HLH, and triglycerides elevated. We've sent soluble CD25. We had to send it to Guy's Hospital in London, so the result was not immediately available. NK cell activity was not done even in the UK, perhaps because of cost effectiveness, cost issues. We did hepatitis B, C serologies, which were negative. EBV and CMV PCR tests on DNA PCRs were done. So the diagnosis of hemophagocytic lymphohistiocytosis was made with 6 out of 8 criteria fulfilling without soluble CD25. And we did MDT, and without waiting for further investigations, we decided to start treatment with HLH 2004 protocol. At this stage, she was really ill, and so she was moved into the ICU and started treatment with HLH 2004 protocol. A few days later, CD25 result came as more than 2,400, meeting the criteria. So we had 7 out of 8 criteria to say that this is SLCH. Still, we couldn't find a precipitating event. So we did a PET CT also, but there was no areas of high uptake. This is just the summary which we've seen during the previous speech also. So moving on, we started with IV dexamethasone and IVIG plus cyclosporine, and the second, but we couldn't give the cyclosporine proper dose, which was 6 milligrams per kg in a BD dose because of her kidneys were not doing very good. And on day 2, we added IV etoposide, which was repeated again during the same week, 2 days later. However, the patient did not respond very well, and gradually she became drowsy. We planned for IT methotrexate, and also by that time, EBV PCR test, DNA PCR came as high. There was a very high value. So we planned to add rituximab. However, we couldn't give rituximab or even IT methotrexate because she passed away, unfortunately, on day 6 of the treatment protocol. I would be discussing more about rituximab later in my speech. So moving on to my second patient who I met at Teaching Hospital Batticaloa a couple of months back. She's a 26-year-old mother of a 10-month-old baby. She was very well before this incident, but before admission, the immediate past 2 months, she has had 3 hospital admissions. The very first one was in July this year with high fever and elevated liver enzymes. And she was managed as dengue hemorrhagic fever at that time with dengue hepatitis. However, dengue antibodies or dengue antigens were not done at the local hospital. And there was no evidence of hepatosplenomegaly in the ultrasound at that time. She was given 1 pint of blood transfusion also because the HB was low, and IV cefotaxime cover was also there. 2 weeks after the first episode, she readmitted with high fever and tachycardia. There was severe neutropenia at that time. This is again to the local hospital. Then they managed as bacterial infection with a query of endocarditis. Because of the severe neutropenia, they've given filgrastim, but the patient left against medical advice. And on the same day, she got admitted at Teaching Hospital Batticaloa. At that time, she had pervaginal bleeding and loose stools also. She was managed as sepsis plus post-viral hepatitis. Blood culture became positive for gram-positive cocci. That was staph epidermidis, which I suspect could be due to contamination. So she was treated with linezolid and cotrimoxazole for 2 weeks and completed treatment. She was discharged on 20th of August. However, even after discharge at home, she didn't feel at all good. Before discharge, the 2D echo was normal, no vegetations, and the ultrasound just showed evidence of some hepatomegaly with fatty liver changes. This is roughly the summary of her investigations during these 3 admissions. If you look at the cell counts, they are somewhat fluctuating, but with the help of blood transfusions as well as filgrastim also. And the liver enzymes also went more than 1,000 on both occasions. So she wasn't really feeling good even at home. She again got admitted on 11th of September. This is the current admission. So apart from the on and off fever and tiredness, loss of appetite and ongoing lethargy, she did not actually have any other symptoms or signs which would point towards any focus of infection or anything. And on examination, she had no focal neurological signs and GCS was 15. She was dyspneic and SpO2 was 92% on air. She had no lymphadenopathy, but there was a moderate degree of hepatosplenomegaly. ECG showed sinus tachycardia, the heart rate was around 130, and the very next day she developed a supraventricular tachycardia, which resolved with carotid massage only, but she was transferred to MICU because of her severe illness. So this is just roughly the initial 4 days of current admission. Neutrophil count was falling down and down, and the hemoglobin with transfusions, it went up again, it starts dropping. And interestingly, at this point, her INR and APTT was also, they were also elevated. So we did a blood picture and there was evidence of evolving MAHA. Rotem showed mild fibrinogen deficiency. Therefore, we decided this could be sepsis with possibly DIC. Then the next batch of investigation results came with the serum ferritin being 84,000 and LDH more than 1,000. She had high triglycerides. Plasma fibrinogen did not meet the criteria for HLH because it was 2.4. However, looking at her inflammatory and infective background, I would expect a plasma fibrinogen to be more than this. So it was like relatively reduced, and Rotem also confirmed a reduction of fibrinogen. Bilirubin, so there was a direct hyperbilirubinemia, and the CRP also was not that high. And we did a bone marrow biopsy with the suspicion of hemophagocytic lymphohistiocytosis, and as expected, we could find occasional hemophagocytic cells. The ultrasound showed only evidence of moderate splenomegaly and hepatomegaly without evidence of malignancy. We did a contrast-enhanced CT scan of abdomen and pelvis also, which showed hepatosplenomegaly only. There was a cystic lesion in the ovary, which they concluded after an ultrasound scan as benign. Further looking at the precipitating factors, ANA was negative, NS1 antigen, dengue antibodies all were negative, HIV antibodies negative, hepatitis BC negative, and EBV, CMV, and TB tests all were negative. We actually didn't wait for all these tests. We had 6 out of 8 criteria positive for HLH. So we concluded this is HLH, and we did a multidisciplinary team meeting with the involvement of the physicians and the microbiologists and the rheumatologist and the hematology team. And we decided to go ahead with HLH 2004 protocol. So initially the patient was given dexamethasone according to the protocol, and we also gave IVIG for 2 consecutive days. There was no significant clinical improvement. On day 4 of treatment, we added cyclosporine and other supportive medication also were given. After 1 week, still we didn't see any significant clinical improvement, but her ferritin came down to 30,000 from initial 84,000. But cytopenias remained the same, and the splenomegaly remained the same, and also the transaminases remained high, elevated. So we decided to combine IV etoposide, and from 2nd week onwards, we added IV etoposide. On the 2nd week, 2 doses were given, but thereafter, only 1 dose was given, and we tapered off IV dexamethasone according to the protocol. After the 8th week, we tailed it off and stopped dexamethasone. IV etoposide stopped, and also the cyclosporine we stopped after completion of the 8th week. Supportive medication-wise, we continued PCP prophylaxis and antifungals as well as PPI. There was a dramatic clinical response by week 3. She was out of the ICU by end of week 2. And by week 3, she was able to sit up on bed. Initially, she didn't have strength to even sit on the bed. And by the 6th week, she was able to walk without support. However, her tachycardia persisted more than 100 beats per minute. So we did a thyroid profile just to find her TSH being very low with the free T4 being high, and also anti-TPO antibodies, that is thyroid peroxidase antibodies, became positive. Unfortunately, we couldn't do the thyroid TSH receptor hormones because it was not available. The medical team started propranolol and propylthiouracil for the patient, for which she clinically improved. So now this patient was doing very good. Now we are at a point to decide whether this is primary or secondary HLH. Yes, she has an autoimmune condition now. She has Hashimoto's thyroiditis in the Hashitoxicosis phase, which will later progress into the hypothyroid phase. So how common is autoimmune thyroiditis in secondary HLH? Well, this is a multi-center study over 7 years, which was published in 2015. They studied 156 patients, and out of that, 19 patients had autoimmune conditions, and 2 of them were with autoimmune thyroid disease. So it is not like unheard of. The autoimmune thyroid disease can be associated with secondary HLH. But at the same time, this patient is relatively young. She is 26 years, and there are well-documented cases of even older patients presenting for the first time in adult life, the primary HLH patients presenting for the first time in adult life. So she's a 26-year-old patient. There was no consanguinity between parents, but her condition was precipitated after her first pregnancy, roughly around 6 to 7 months after pregnancy. So we had to consider whether this is a primary HLH also. We actually planned for NGS to be sent to India for a full panel. It costs 250,000. And unfortunately, with the current economic crisis in Sri Lanka, we were not given approval by the Ministry of Health. And the patient herself is willing to do the test, but she also can't afford. So she is willing to collect some money and go ahead with NGS, probably in the near future. And what is the difference between HLH 94 and 2004 treatment protocols? In the earlier speech, we saw that they have treated their patient with 94 protocol. So is there any difference between HLH 94 and 2004 protocols? If we compare these, HLH 94 doesn't have cyclosporine in the initial therapy period. They start in cyclosporine in the continuation phase. But in 2004 protocol starts off with cyclosporine also. And also IT therapy is combined with prednisolone, whereas in 94, IT therapy is only with methotrexate. So is there any significant difference between these two protocols with regards to the outcome? Well, what the studies have showed is that there is a borderline statistical significance in reduced pre-transplant mortality in patients who are being treated with 2004 protocol. But as it is a borderline borderline clinically significant one, I don't think there is any significant difference if you choose to treat with either of these protocols. So now our patient is back to her usual self. She's doing all her work and she's taking care of her baby by herself. So where do we go from here? Now we treated the patient with initial 8 weeks of chemotherapy. What the 2000 protocol says is to continue therapy until transplant if it is genetically verified familial disease or if it is persistent non-familial disease. If the disease is resolved, we can stop treatment, and if there is reactivation only, we can pursue with continuation of therapy. So we are following this pathway at the moment as she is very well. So in my first case, I spoke about rituximab for that patient. So it is not incorporated in HLH 2004 protocol. So what is the place of rituximab in the treatment of HLH? Well, it is basically used in the treatment of Epstein virus-induced hemophagocytic lymphohistiocytosis because it can reduce the viral load. EBV virus lives inside B lymphocytes, so anti-CD20 antibodies will go and kill those B lymphocytes, so the viral load is markedly reduced and the patient will be benefited. So that brings to the end of my speech. I'm happy to try any questions if you have.
Thank you, Dr. Tamatika. Thank you for your excellent presentation HLH and giving in a brief description regarding the management of HLH and comparing the different protocols and what is the benefit of having a 2004 protocol. And so if you have any questions, you can post in the chat box, so you can ask now. She's happy to take any questions. I think there is no question for you, Tamatika. Okay, so since we don't have any questions, I take this opportunity to thank for all the speakers, the trainings from Candy Cluster and Gold Cluster for their excellent presentation and sharing their knowledge and enlightening the audience regarding the different variety of cases. And also, I should thank a big thank you to Mrs. Sugi De Silva, who is supporting us with IT in the other side, like Carmen White, and she's supporting us. So it's a big thank you for her. And also a big thank you for accepting and doing a presentation in Young Hematologist Forum, the both speakers, Dr. Tamatika and Dr. Chamindi, thank you again. And also, at last but not least, a big thank you for all the audience to take part in this forum during the festive season, because everybody is in a mood of celebrating the festive since we are heading to the year end. So though with a festive mood, you have joined and you have really listened patiently the speakers, the presentation. Thank you again, once again. And so if we don't have any questions, then so we should be able to wind up now. Thank you so much.